No, totally understood. You guys figure it out. Let us know. We'll just be here doing the song and dance. Okay, bye-bye.
Geez, sorry guys, scales, little technical trouble, and I seem to usually not have trouble. So I guess it means that COVID's over and we can just go back to in-person meetings. No, I'm just kidding.
Josh problem.
Kind of what it feels like though. You hear me okay? All right, I am just waiting. I'm Josh, I'm the stroke program manager. I'm at Upstate. I'm just waiting for Dr. Galgano to join also. He's one of our neurosurgeons and I was hoping he could start and talk about spinal emergencies, but he's having a little trouble too. So if you guys have any housekeeping things to chat about before.
There he is.
He's there now. Great.
Josh.
All right. Hi, Dr.
It took a while
Galgano.
to log in. For some reason that none of the links were working.
We had a little trouble too. It's all good. We're here now. One big happy family.
All right, just give me 2 seconds to just pull it up, okay?
Yeah, absolutely. Josh, are you okay if we just start whenever Dr. Galgano is ready?
I will do everything I need to do at the end of the night.
Sounds good.
All right, can you guys see the screen?
Yes, sir.
Awesome.
I didn't introduce you or anything, Dr. Galgano, so go ahead.
That's okay. So I'm one of the relatively newer neurosurgeons at Upstate Hospital in Syracuse, New York. I did my residency training here from 2010 to 2017, and then I went off to Brown University 2017, 2018. I did a complex spinal deformity oncology trauma fellowship, and I've been back on board as an attending for I guess close to 3 years now. So I'm going to give a talk tonight on emergency spine management, and hopefully this is this is of some value to all of you guys that are all of our first responders out there. All right. So Josh, about 30 minutes, right? And then there should be.
You muted yourself.
He either muted himself or we lost audio with him.
Nope, I muted him by mistake. I'm real sorry. Like I said, I'm usually good at this. So, Dr. Galgano, yeah, 30 minutes or so, and then the group can ask questions. I'm sure you have some good stuff, and then Reyes and I will take over, and you can bow out when you're all set.
All right, sounds good. All right, so I'll just start off with we'll go over some objectives. We'll try to discuss some common presentations of spine emergencies. Spine emergencies are actually relatively uncommon. I can't say that we see a lot of them. Cranial emergencies are completely different animal. When we have patients that come in with brain hemorrhages and are actually dying, they're herniating, they have a blown pupil, those patients need to be rushed to surgery. From a spine perspective, though, there's relatively few true spinal emergencies, but I'll try to go over about 4 or 5 of them that we do see on occasion. So as far as what are the true spinal emergencies, I would say highly unstable fractures, dislocations, things like AO dislocation, which, the press likes to talk about internal decapitation, where the head internally kind of disarticulates from the spine. That's a spinal emergency. Ankylosing spondylitis fractures, which we'll talk about in a little while, those are highly, highly unstable fractures. Anything that's causing traumatic spinal cord compression in an acute fashion. We see lots of patients in clinic that have severe spinal cord compression, but it's not acute compression. So the spinal cord has kind of some time to tolerate that degree of compression. Acute epidural hematomas, we usually see this with maybe some low impact traumas or patients who are hypercoagulated or have anti-hypercoagulation on board, such as Coumadin, Pradaxa, Eliquis, aspirin, things along those lines. And then more uncommonly, we'll see impending spinal cord infarction from abscesses and tumors. Let me just see if this goes to the next slide. So as far as pre-hospital optimization, which is relevant to all of you guys that are our first responders out there, and all of you know this as good as anyone, maintaining spinal neutrality is very important, right? So avoiding neck, head distraction. A lot of times we think that applying a cervical collar is good and is very benign, but there are some interesting situations such as AO dislocation, ankylosing spondylitis fractures, where applying a cervical collar may actually be more dangerous. But obviously out in the field, there's no way for you guys and women out there to know that this is going on. But I do want to show you some examples where we could actually hurt people by putting a collar on them, believe it or not. Blood pressure is very important. We want to avoid hypotension in the spinal cord injury state. Hypotension is a known etiology for secondary spinal cord injury. So if we have spinal cord neuromonitoring changes during an operation that we're doing, we will typically try to jack the blood pressure up iatrogenically. O2, we want to avoid hypoxia. That's kind of along the same line of understanding as avoiding hypotension. Being aware of ankylosing spondylitis. All of you guys have heard of this, correct? Out there, ankylosing spondylitis or DISH, diffuse idiopathic skeletal hyperostosis. So I'll go into a case example and I'll show you where you could actually run into pretty significant airway issues and how we can hurt someone's spinal cord by not being very, very careful with their spinal alignment. And I think this is one of the most important things, and we unfortunately see this a lot at Upstate, is having patients transferred from outside facilities, especially with brain injuries and whatnot, where maybe they were brought to a different hospital and they should have been brought to a trauma center first. And a lot of this is based on the geography of where the patient has their trauma or their spinal emergency. So I'll go over about 4 or 5 cases with you guys. And these are all real cases. I actually do have some intraoperative surgical video just to kind of show you, the downstream effects of what some of these injuries are from the time that you guys see them out in the field. So this is a lady I took care of a couple of years or so ago. She's a 57-year-old lady, and she thought she was actually having an MI. So she took a nitroglycerin, and it made her hypotensive. It turned out it ended up being reflux disease. So unfortunately, when she became hypotensive, she passed out and she struck her head on the wall. And neurologically, she came into us essentially a quad. She had positive perirectal pinprick sensation, but she had no rectal tone. She had a positive bulbocavernosus reflex. She had no movement from her deltoids all the way down, but she was able to utilize her cranial nerve 11. So she did have some shoulder shrug, but otherwise she was awake, alert, actually breathing spontaneously, unlabored. Her heart rate was 42 and her blood pressure was 70/40. So right now we're starting to think she has some type of a spinal cord injury. Maybe she's in neurogenic shock. So this is what the CAT scan looks like. And I know you guys probably don't look at these too often. This is a lateral projection of a CAT scan here. And what we could see at the level of C4 over C5 is that there's a sagittal plane malalignment here. C4 has subluxed or disarticulated over C5 here. And essentially why this has happened is that they've developed what's called a jumped or a locked facet. So if you look back here, this is the normal facet complex. One facet should be riding over the other posteriorly. But if you look over at the abnormal one, you can see that this facet of C4 has completely jumped over the facet of C5. So just for reference, this is what they should look like, below and above. So when that happens, as you can imagine, the spinal cord is completely kinked almost at 90 degrees in this orientation. So the spinal cord essentially gets severely compressed. So in this situation, just like we like to say time is brain, we also like to say time is spine. So this is a situation where the spinal cord is not severed, and there's definitely time that, time is of the essence here, where we really want to try to decompress the spinal cord as soon as possible. So when we describe this patient, we have to look at several factors. What are their vital signs? And we talked about that. The patient's heart rate was 42. The blood pressure was 70/40. So we have to start thinking that this patient may be in what's called neurogenic shock. We look into the reflexes. Is the patient in spinal shock? And then we also have to look into what their neurological assessment is overall. Is this a complete or incomplete spinal cord injury? So for this patient, she's what we call C4 Asia B. She's an incomplete injury. Reason being is that even though she had no movement from her shoulders down, she did have preserved perirectal sensation, which categorizes her as a C4 Asia B, and she was not in spinal shock. So for those of you that are not aware, there's a difference between neurogenic and spinal shock. Neurogenic shock essentially is when there's any type of a spinal cord injury above the level of T6, and the sympathetics basically get affected. So what happens is that these patients develop bradycardia, hypothermia, and hypotension. And like I said, it's an interruption of the sympathetics. The parasympathetics are left unopposed, and these patients will develop bradycardia. And you have to be very careful about giving these patients phenylephrine, because that can actually exacerbate their bradycardia from the spinal cord injury. So in the hospital, a lot of these patients will get treated with hypervolemia when the blood pressure is low, and that's actually not the right thing to do because these patients will then go into pulmonary edema. So they have what we like to call a relative hypovolemia. Spinal shock is completely different from neurogenic shock. This is the temporary loss of all neurological function below the level of their spinal cord injury. And essentially what these patients present with is flaccid paralysis. They have completely areflexia, and this can last a variable amount of time. So when we formulate an ASIA scale, a lot of times it's not accurate in the first 72 hours or so. So we have to check what's called the bulbar cavernosus reflex. Once that reflex comes back, that tells us that the patient no longer is in spinal shock. So all of you know this, spinal cord injury management, first things first, ABCs, right? We have to maintain their airway, pressors if necessary. Iatrogenically, we do try to get their blood pressure up to about 85 or 90 and care for hydration as well. And we talked about the different ASIA grades. ASIA E is not on here, but ASIA E is completely normal. ASIA A is when you have complete spinal cord injury. There's no motor or sensory level below the level of the lesion. ASIA B is a complete motor loss, but you do have some preserved perirectal sensation. ASIA C is when you have a less than 3 out of 5 motor grade strength below the level of the injury. And the ASIA D is if you have greater than 3 out of 5 in most muscle groups below the level of the injury. And this has a lot to do with the prediction of motor recovery. So patients who are ASIA A, they have a much less chance of recovering to an ASIA D or E. However, the higher up on the ASIA scale you get, the higher the chance that you're going to end up improving as close back to normal as possible. I'm going to skip over this for a second. This is important to keep into consideration as well about acute pulmonary considerations. So all of these patients, even if they have a thoracic spinal cord injury, a lot of these patients will still end up having some element of pulmonary compromise. And reason being is that their accessory respiratory muscles are down, just like all of their extremity muscles are as well. Now, this is not something that as paramedics and first responders you have to be too involved with, but this is always a big debate within the spine surgery world is should we or should we not give these steroids? There's been a number of studies many years ago saying that steroids are bad. Typically, if I have a young patient with an acute spinal cord injury, I will typically put them on a methylprednisolone drip. Only reason is that there is some sufficient evidence showing that they can actually increase a motor grade strength if they're put on the methylprednisolone drip within about 8 hours of their spinal cord injury. I'm going to skip by all of this and kind of show you what we did for this patient and what some of the options are when these patients come into the hospital. So as you can see, this is a different patient, but a similar mechanism to that last woman that I showed you where they have a jumped facet or subluxation. And this is what the spinal cord looks like down here. It's completely kinked. So one of the first and quickest ways that we can actually decompress the spinal cord is by putting them in what we call traction. So we'll put Gardner-Wells tongs or a crown halo onto their head, and we basically hang a certain amount of weight, or sometimes we can actually manipulate that traction device to try to pop those joints back into place, and that's called a closed reduction. Another method we could utilize for stabilization, not for this particular case, is this is a crown halo vest, and then this is the Gardner-Wells tongs, which I was referring to. Traction. So operative timing. So how urgent is a case like this? I would say it's very urgent. This is one of the few situations where patient hits the door. We make sure that they're medically optimized. We try to get them to the operating room as quickly as possible, right? And there's plenty of literature that's supporting getting these cases done within the first 24 hours. I personally try to get it done as soon as I can. If I'm operating when a patient comes in with an acute spinal cord injury, as long as they're medically stable and optimized, I'm taking them right after the surgery. So I do try to get to all of these within a couple of hours if I absolutely can. And I do think that there's sufficient evidence in supporting that. So as far as the type of surgery here, we can do this from the front of the neck. We can do an ACDF. ACDF is when we essentially get a small graft and we put it between the vertebrae. We can do this all from the back, and we can put multiple pins and rods in. And that's essentially what we did here. We tried to put this lady in traction because it was about midway down her subaxial spine. We did have trouble actually reducing the subluxation. So we were able to put pins and rods in through the back, and we were able to utilize a high-speed burr to drill out that subluxed fracture here, essentially to get her into better position. And even though she does have the normal sequelae of a spinal cord injury, spasticity and whatnot, she's actually made a fantastic recovery. She's not ambulatory yet, but she's definitely regained a lot of strength in her arms and some element of utilization of her hands as well. And I've actually maintained my friendship with her over the years, and she's a very close friend now. Does anyone have any questions about that case? That's a pretty typical case of what we like to call a jumped facet. All right, so I will move on then. This is another case of a 71-year-old gentleman who presented to us with a rapidly progressive paraplegia after a very minor fall the day previous. And pertinent medical history here is that he has a history of atrial fibrillation and is on Coumadin. So when a patient comes in after a minor trauma like this, just from a fall from a standing position, you have to start thinking, why are they neurologically not intact? And he basically came into us as a paraplegic, essentially, and his INR on admission was 2.65. So the first thing you have to think about is there an extra-axial hematoma that is compressing the spinal cord? And that's exactly what we see here. So this is another true spinal emergency where patient comes in, they're on blood thinners, they develop an avulsion from a minor trauma of an epidural vein. One of the veins opens up and it basically spills blood into that epidural space here. And there's obviously no egress route for extravasation of the blood. So it just keeps pumping, and it severely compresses the spinal cord. So a patient like this necessitates urgent evaluation and needs to go straight to the operating room. If they're not there within a few hours, what ends up happening is that they develop a vascular event to the spinal cord, and they essentially have a spinal cord stroke or an infarct. So this gentleman, we were able to take the surgery within about 3 or 4 hours of this presentation to us. We did have to reverse the INR. This is the post-operative MRI scan, just for comparison of what this looks like. This is the pre-op on the right. This is the post-op on the left. You can see he reaccumulated just a little bit of blood here, but he's made a fairly nice recovery. He's starting to regain some motion and sensation in his legs now. He's only a few months out of surgery from the index injury that he had. So this is an example of an acute epidural hematoma. This is a gentleman that I took care of when I was a fellow at Brown University about 3 or 4 years ago. He's a 42-year-old gentleman, and he presented with an injury that's very easily missed. And I'll show you what I'm referring to here. He fell from about a 30-foot ladder. He was a polytrauma, came in multiple rib fractures, needed to be intubated on the field, multiple lung contusions, but he was maintaining quite well. He had a GCS of an 11T. He was grossly full strength in all of his extremities. And at first glance of this, you may not notice, even to a well-trained eye, that there's anything that looks abnormal here. The facet joints look like that they're relatively intact. If your eyes are drawn to this is actually not a fracture. This is just the cut that we see through this sagittal profile here. But what you can notice here is that this is part of the base of the skull. It's called the occipital condyle, and this is the C1 lateral mass here. And what you can see that there's a very significant distraction of the occiput to C1 joint. It's called OC dislocation. And this is what I was referring to earlier about internal decapitation. This is a very, very dangerous condition here because the brainstem can develop a significant injury from something like this. And if you look closely at the coronals, you can see that his occipital condyle is fractured here, and there's significant gapping here. So, this is really not a bone fracture type of a pathology that worries us. The fractures of the occipital condyle can heal on their own. It's when the ligaments get splayed apart like this, and these are highly, highly unstable. And even to the very well-trained eye, these can easily be missed. So when this patient first came in, he was moving all of his extremities. He was also found to have a bit of a brain hemorrhage as well. He had some subarachnoid hemorrhage. He had a little bit of hydrocephalus. He ended up needing an external ventricular drain to siphon off his spinal fluid because he had water on his brain. But unfortunately, because of this stretch injury, he developed significant bleeding into the posterior fossa of his brain and also to the back of the spinal cord here. And this is just an artist depiction here of what this looks like, where you have this internal decapitation or OC dislocation here. And there's a variety of different types. There's a type 1, where the head essentially is anteroflexed relative to the spine. Type 2 is when it's completely distracted, and type 3 is when it's posteriorly oriented. In real life, though, we probably see all 3 of these, right? Because the head and the spine is so incredibly unstable that depending on how the patient's head is positioned, you could probably see type 1, type 2, or type 3. So we have to think about treatment options. And earlier I was kind of alluding to how a cervical collar can be dangerous. And obviously you're not going to know out in the field that a patient has OC dislocation. But once a patient comes into the hospital and we have evidence of that, a lot of times we'll actually try to take the cervical collar off of them. And the reason being is that these collars have a tendency to hyper distract or hyperextend the head on the neck. So the classical teaching is that once it's proven that a patient has OC dislocation, we try to take them out of the collar and we'll put sandbags on the side of them. And then we'll put them in halo vest, and then we'll actually take them to surgery and, believe it or not, fuse their head to their spine. It's a very big operation. It's a very morbid surgery, but that's essentially what's necessary to keep these patients stabilized. These are some artistic renditions of what an OC stabilization looks like, where essentially we'll put a plate on the back of their head. We'll put multiple pins and rods into the top of the neck and then connect it to their head. And for the rest of their life, their head is completely fixated to their spine. They can't flex, they can't extend, and they can't rotate their head. But at least the head on neck is essentially stabilized. So with this particular patient, we ended up taking him to surgery. And this is what we did for him. We put multiple pins into the bones of his neck called the lateral mass. We had a long rod that extended all the way up to his occiput. Now, he also developed a hemorrhage in the back of his brain. So we actually had to decompress the back of his brain as well. So we had very little surface area to put one of those plates. So we were able to put pins into his occipital, into what's called the inion, the occipital bone here. And then you can see we also ran a wire through the back of his head to this J hook here to link him up, just to ensure that this is a stable construct. And these are just some other depictions of what can be done for something like this, where we have to do posterior fossa decompression, decompress the back of the brain, but at the same time stabilize the head to the spine. And these are just different renditions of constructs that we could utilize for something like this. So this is a very unstable injury. And again, in the field, you guys obviously are not privy to radiographs there. I would just advise you, just keep them in a cervical collar. Just be cognizant of not hyperextending them too much. Some of these collars these days, they have these rotational elements where you could flex or extend the head. I think the ones that most patients come into upstate with in most trauma hospitals is a fairly standard one. And I don't tend to find patients that are hyperextended, but it's just something to keep in mind that this is a very dangerous condition. These are highly unstable injuries. Any questions that you guys have about AO dislocations or acute epidural hematomas before I move on to a couple of other cases?
Hey, I have a question, actually. It's Josh.
Hey, Josh.
What are common causes of this? Did I miss that?
Yeah, so this gentleman fell about 30 feet from a ladder. It's usually high-speed motor vehicle collisions, usually falls from height, things like that. But I would say 99% of the time, it's usually a high-speed motorcycle accident. Very, very large percentage of patients that do have AO dislocation actually don't even make it to the hospital alive. They'll essentially have a stretch injury to their brainstem or their upper cervical spine. They'll go into respiratory arrest, and before we can even get to them in the hospital, they'll essentially pass away on the field. So we do see that sometimes. I know a lot of times our paramedics and first responders, unfortunately, find people that don't make it, and a lot of times it is secondary to AO dislocation. We just never have radiographic proof of that because they pass away by the time they get to the hospital. This is another trauma case that we took care of about a year or so ago, last winter. This is a 21-year-old unfortunate kid, and he was intoxicated and riding a snowmobile, which is usually a fairly bad choice to drink alcohol while you're riding your snowmobile or an ATV. So we see this, Josh knows this, we see this a lot at upstate. We see in the summer, we see all the ATV accidents, mixing fun with alcohol. And in the wintertime, we see snowmobile accidents where these young fellas come in that are heavily intoxicated. So he came into us with a C4 Asia A, completely out. He did have a positive bulbar cavernosus reflex, which tells us that he's not in spinal shock, that this is a true Asia scale. And this is a very, very severe fracture that you can see. This is C2, C3, 4, 5, and at C6, you can see that he has what's called a traumatic burst fracture. And not only did he fracture C6, but you can see on the AP or the coronal cut, he's actually has what's called a pincer fracture. It's a vertical axial loading fracture of the vertebrae directly above and below that index level here at C6. And these patients don't tend to do as well as that first lady did. If they have a jumped facet or a locked facet, relatively easy to get their spinal cord unpinched with traction or with drilling out their facet joints. In this situation, these are usually fairly asymmetric, sharp fragments of bone that have impaled the spinal cord. And you can see here the degree of spinal cord compression that he has. He's got what we like to call T2 signal changes to severe swelling of the spinal cord at multiple levels here. So this gentleman's going to have a tough time recovering. We do have to worry about his respiratory state after surgery as well. Just to give you a bit of taste of what these surgeries are like, they can be very bloody because the vertebrae is very hypervascular, and the vertebrae essentially has kind of imploded on itself with this injury. And this is through the front of the neck. And what we're doing here is what's called a corpectomy. So we're trying to drill out the vertebrae of C6 and C7 and essentially decompress the spinal cord as quickly as we can. Now, Josh, is this video coming through? Is it kind of jagged, or can you see it pretty good?
Pretty
Oh,
good.
it's coming through. Yep.
Good. So this is the spinal cord here. This is us removing all of the bone fragments that are on it. This is me just trying to size up the implant that we're going to put in here, because now we've essentially taken out 2 vertebrae. We've completely decompressed the spinal cord. So now we have to put in a strut. You could use a fibular strut. You could put in an expandable cage, something like that, that takes the place to ensure that the spinal cord is stable. And then what we do is we utilize bone graft in an effort to try to get this to completely heal up over time. And then once that cage is in, we're able to place a plate, and then we put pins into the vertebrae above and below. Because this injury is so incredibly unstable, we end up taking the patient for a posterior fixation, decompression, and fusion as well. So essentially what we want to do is we want to obtain a complete 360-degree circumferential spinal cord decompression and stabilize the patient. That way he could eventually go on to rehabilitation. And this patient ran into all sorts of complications after surgery. He actually ended up requiring a pacemaker. He was going asystolic every time the nurses turned him. So he's had a very rough go afterwards, but this is a surgery where it's a young guy. We do want to try to get to him as quickly as possible. This is another interesting case in the last couple of minutes. I know we've got about 5 or 10 minutes left before questions. This is a 32-year-old lady who actually works at Upstate, who had a high-speed motor vehicle collision, and she had what's called a conus medullaris lesion. So she had good strength of her lower extremities. Her issue was that she was retaining urine. And when we bladder scanned her, she had about 1,000 cc's in there, which tells us that she's has what's called a neurogenic bladder. And if you look closely at her scan, you can see that at the level of L1, she has a traumatic burst fracture. Luckily, this part of the spinal cord is a bit more forgiving than the upper cervical or the mid-thoracic is. So this is right at the level of the base of the spinal cord here. And if you look at the axial cut, you can see the fairly large retropulse bone fragment that's sitting right on her conus here. So this is another patient. She's got a spinal cord injury, but not as bad as the previous 2 people or so. So this is still someone that's very salvageable. This is someone that we do want to try to get to surgery relatively quickly. And I'll kind of jump ahead and show you what we do for this kind of surgery, where we open her up about 2 levels above and 2 levels below. And then we like to put our pedicle screw fixation in above and below to stabilize. And there's a few different ways we could do this. We could actually go through the back of the belly. If it's thoracic, we could go through the chest. I typically prefer going through the back because it's a single position, it's a single operation, it's a single anesthetic event. So after we put our stabilizing pins in, we'll do what's called a laminectomy, where we remove the back of the spinous process, the lamina, the facet joints. And then that gives us access to the dura, or the spinal cord. And I'll kind of jump ahead a little bit for the sake of time. Now that we've taken out the backbone, the spinous process, you can see that this is the spinal cord here, and the nerve roots are now exiting their respective tunnels or neuroforamen. Now what we're doing is we're cutting the disc. You guys have all heard of the doing a discectomy. Well, this is a discectomy so that we could essentially remove the disc above and below the fractured vertebrae, and then try to fragment that fracture even further, and then take it out in a piecemeal fashion like what we're seeing here. So again, this is the dura of the spinal cord. This is the L1 nerve root. The T12 nerve root is up here, and now we're getting a drill, and we're drilling out those fragments that are in front of the spinal cord, trying to deliver them in these small little corridors between the nerve roots that we need to preserve. In the lumbar spine, all of these nerve roots are highly functional, so we can't cut them. In the thoracic spine, there's not a lot of contribution to motor activity outside of the intercostals, so we could usually cut those with impunity if we have to get in front of the spinal cord, but in the lumbar spine, we can't do this. This is a much more dicey operation, doing this right at the thoracolumbar junction. And then after we take out these bone fragments, we basically pack it. We obtain some good hemostasis, meaning blood control here. And then I'll show you what we put into that space to take the place of it is we use something very similar to the last case. We're able to sneak one of these expandable cages in and sneak it right in front of the spinal cord around the nerve roots. And then we're able to put our stabilizing rods in afterwards. This is what it looks like with the cage going in. Again, this is a very dicey maneuver. We don't want to rupture the dural membrane. We don't want spinal fluid to leak out. We also don't want to cause undue traction on that nerve root there so that the patient doesn't wake up with a neurological injury. I mean, keep in mind, this is a patient who has good lower extremity function. She's got some neurogenic issues, and she actually did remarkably well. So she went back to nursing at Upstate about 6 to 8 months after this, and she's doing fantastic right now. And I'll show you what her post-op films look like after. And this is what the cage looks like once we put it in. These are the stabilizing pins above and below that. And this is her post-op 6-month x-ray, and she's doing fantastic. So, you know, it's really rewarding when you get a case like this, when someone comes in that's actually salvageable. A lot of these upper cervical injuries, unfortunately, are not very salvageable, but we still do try to get to them in time. And one last case I want to go over is case of ankylosing spondylitis. And these patients have a type of a spine that we like to refer to as a bamboo spine. They develop autofusion. And this is akin to a long bone fracture, the humerus, or maybe of the femur or the tibia. The only problem is that we've got a spinal cord sitting in the middle. So you can imagine when a long bone fractures, you have these two lever arms above and below, and it's a high degree of instability. But when that happens to the spine with these autofused spinal segments like this, the spinal cord is in the middle. So this is a gentleman who had a very low impact fall. And again, even to the untrained eye, you could see that right here, there's a large gap between the vertebrae, between C4 and C5 and between C7 and T1. So this gentleman has completely disarticulated his spine here. And I don't know how, but he came in without a spinal cord injury, actually. So these are patients that you have to be very, very careful with as far as transporting them. I think it's worth asking patients if you suspect that they have a spinal cord injury or any type of a trauma for that matter, if they have a history of ankylosing spondylitis. And the reason being is this is not the same patient, but imagine trying to intubate this patient in the field. So if you have this patient in a cervical collar and they're hyperextended like this, their trachea runs right in front of their spinal column. Their esophagus is here, their trachea is right in front of that. Imagine trying to intubate this patient in the field. If you're trying to get that ET tube down, you're going to run into a lot of problems. So these patients, you really do not want to have hyperextended, right? These are patients that you want to make sure where their head is actually propped up and not extended like this. So this is just a good example is, you know, the challenges that you guys would face intubating one of these patients. And some of these patients, if they do have a high spinal cord injury, they're going to lose their airway. And then you have to be prepared to do a cricothyroidotomy and get these patients airway controlled right away. And this is just a depiction of what their spine looks like once you put a bolster beneath their occiput and their head so that you could finally realign their spine and, more importantly, realign their trachea so that you can get them intubated if possible. And this is just another depiction of what an ankylosing spine fracture looks like. This is another example of a case that I did several months ago. This is a patient who came in an outside hospital. He had a fracture that looked like this. When he came to Upstate, we rescanned him, and it doesn't look like he has a fracture anymore. In the front, it looks like he has a fracture in the back now. And again, that's because this is a highly, highly unstable fracture. These are just some other examples of similar type of fractures where the spine will completely disarticulate from itself. And we have to put multiple pins and rods above and below in these situations to get these patients stabilized. So this particular gentleman required a posterior decompression as well as a stabilization with multiple pins and rods. And I don't know, Josh, I forgot. I think I do have one more case here. Do we have time for one more case, or do you guys want to? Yeah. Okay. So we'll proceed with the last case or two that we have. This is a 14-year-old male. This is kind of a combination of a trauma and an oncology case that turned into a very urgent situation. This is a 14-year-old kid who had seen his pediatrician because he was having some trouble with dexterity in his hands. And if you look at his plain x-rays, you can see that he has a deformity in the cervical spine, a sagittal plane deformity here. He also has a bit of a coronal plane deformity. His head is kind of kicked off towards the right side. His head is a little bit pitched forward, and he's got some type of what we like to call a lytic process going on here. This is all in the outpatient setting. It looks like he's got a traumatic fracture. This is actually not a traumatic fracture. This is what we like to call a pathological fracture, where an infectious disease or a tumor essentially erodes through the bone of the spine and renders it unstable. If you look at the axial cut here, spinal cord is severely crushed here. So unfortunately, this young fella was referred to our neurosurgical department, but before he could get to us, because he was so incredibly myelopathic, he tripped and fell at school, and he came in through a trauma bay as a spinal cord injury. So when we scanned him in the hospital, his inpatient MRI scan looked very similar to the outpatient MRI scan. The only difference is now that he fell, he essentially developed a spinal cord injury. And when we injected gadolinium into his veins, we noticed that he had enhancement of this. So this is not a traumatic fracture. This essentially is an oncology case. He's got a spinal tumor that rendered him unstable. He became myelopathic, he fell, now he comes in as a spinal cord injury. We also appreciated that he had no bone in the back of his spine at this level. So whatever process is going on essentially ate away at the bone here. This is an intraoperative surgical video. This is the level of C3 up top, and this is C7 below. And essentially what we're doing here is we're taking the disc out, just like we did at the last case. This is a little bit cleaner though. Because it's an oncology case, we wanted to try to stay out of the substance of this tumor. We didn't have time to biopsy it to find out what this is. So essentially what we were able to do is take out C4, C5, and C6 on block in a single piece with the tumor that's inside of it. And this ended up being a benign tumor. It's called a hemangioma. But either way, we were able to send it off for pathology to get a specimen sent off for to make sure that this is not a true malignancy, which thankfully it was not. This is the spinal cord that's exposed here after we took out all 3 vertebrae on block C4, C5, and C6. And then we have to reconstruct the front part of the spine here with an expandable type of a cage, just like we did in that last case. Secure this with a plate, pins, and then take him for a posterior operation where we put pins and rods into the back. And he's also had a pretty rough go, unfortunately. He did regain some function in his hands. He's still having some trouble moving his legs. But again, the goal is that we really want to try to decompress, stabilize these patients, and prevent any type of secondary spinal cord injury as much as we possibly can. And this is what things look like in the posterior part of his spine. So he ended up having what's called a hemangioma. About 12% of the population has a hemangioma. Of those 12%, a very, very, very small percentage will have what we call an aggressive hemangioma, where the process will essentially attack the cancellous part of the bone and render it unstable, like in this unfortunate kid. And this is the type of a posterior construct that we have to do to keep his spine in an upright position. Gosh, I guess I had one more case, Josh. I keep saying that. I'll tell you one more case. This is a 37-year-old guy that we saw about a year or two ago, and he has a history of a seizure disorder, and he presented to us after he noticed that he couldn't use his hands and walk anymore. And essentially what we found was that he had a very large retropharyngeal abscess here in his throat. You could also notice some enhancement around the spinal cord. And you could see that he's got this kind of dark configuration in the back of the spinal cord here too. We don't see any nice white signal, which indicates spinal fluid here. So there's something that's compressing his spinal cord. And when we inject gadolinium, it looks like that he's got a rim enhancement here. And essentially he developed a very urgent situation where after he had a seizure in a parking lot, he fell, developed all these abrasions on his face, and these abrasions became infected. And our theory is that it somehow spread to his spine, and he developed a very large retropharyngeal abscess, which then seeded the vertebrae, the disc, and then the epidural space. Unfortunately, with this abscess, he also blocked off one of his transverse sinuses in the internal jugular vein. So this guy was in the world of hurt when he came in. He was very weak. We ended up taking him for a 2-level vertebrectomy. We took out the infected vertebrae, washed out the abscess in front and the back of the spine. We also had to put multiple pins and rods in. Subsequently developed a brain hemorrhage from his sinus thrombosis. And our vascular specialist, Dr. Gould, was able to help us to do what's called a thrombectomy on him. So he's actually had a fantastic outcome, despite the fact that he was in a very tenuous state when he came in. So that's all I have for you guys. I know that was a lot that I threw at you. Again, spinal emergencies, relatively rare. Tumors, infections, trauma situations, epidural hematomas, those are really the main things that we see in a tertiary care center like Upstate University Hospital. So I'd like to open up the forum if you guys have any questions or comments for me at this point.
Hey, Doc. with the 14-year-old, we all know that we keep growing. Is he going to need like further surgery to like expand as he grows, or how is that going to work?
Yeah, it's a great question. So in the real small children who are less than 5 or 10 years old, those children, a lot of times they obviously will kind of grow out of their constructs. And what ends up happening that we find over time is that part of the spine will essentially become underdeveloped. So in the really small children that have scoliosis, we can utilize something called growing or magnetic rods, where as the child grows, we actually can have a magnet and we can expand that hardware over time or go in there and kind of extend it up and down. That's really relegated to the children with scoliosis. With these kinds of children, though, he's 14, 15 years old, probably doesn't have a lot of growth potential left. So he's probably not going to be left with outgrowing his hardware, if you will. But it's a great question, though. I can't say that I've seen that too much. I mean, the youngest kid I've ever operated on and done a fusion on is a 6-year-old. And a lot of times with these short segment fixation and fusions, we'll have to go in there, take the hardware out over time just to allow their spinal vertebrae to have maximal growth potential over time. But in a highly unstable injury like this, or a tumor, where they're essentially missing 3 contiguous vertebrae, the back joints of their neck, we just have to make do with what we have and keep our fingers crossed that they don't run into any issues afterwards.
Okay, thank you.
Sure.
I have a question for you. If we're out in the field and we encounter these people in source of their trauma, so a car accident or they've fallen or whatever, should we be encouraging them to self-extricate from the situation, or should we be like doing all of our, Kendrick extraction devices, collaring, backboarding, things like that? I mean, practically when we see them in the field, when we run into them at the source of the trauma, should we be encouraging?
John, first, John, it's great hearing from you, John. Yeah, John, it's a great question. So I would advocate for not having them self-extricate themselves if possible. Especially if there's any type of neurological impairment. Now, honestly, I've had a few patients who are heavily intoxicated, either with drugs or alcohol, and they come into the hospital and they have an absolute heinous looking injury. And then when you talk to the paramedics, you heard, yeah, we found this guy that was running down the street, after his injury or something like that. And you just, thank God he didn't sublux his spine. But I would advocate for having these patients not self-extricate and using every device that you have to try to take them out of their car or whatever vehicle they're in to try to keep their spine stable. And a lot depends on the mechanism of injury too, right? If this is, a person who falls from a standing position, that's a lot different than a patient who's in a motor vehicle accident or a high-speed car accident or something like that. If there's a high mechanism of injury, high speed, I would advocate, do everything you can, keep their spine stable.
Okay, thanks.
With the halo, if that's something we're gonna see in the field potentially.
No, a halo is something that you would never see in the field at all. A halo vest is something that we put on once patients get to the hospital. Before we apply that, we have to make sure that their spine is completely in a neutral position. We don't want to apply a halo vest to them either in a hyperflexed, extended, or distracted position. So that's something that we need x-rays for. We need a CAT scan, and more than likely need an MRI as well before we would even consider putting a halo vest on someone.
What about your patients who are discharged from hospital in a halo vest? What do we need to do? What do we need to know about halo vests? What do we need to be aware of?
So these patients, when they leave the hospital, they should have a small wrench that's attached, right? There are certain situations where you run into where, God forbid, I've only seen it like once or twice, where one of these halo pins can actually erode through the skull and, God forbid, cause a subdural hematoma, epidural hematoma, or a bad infection. So these patients need to have one of these small wrenches that's actually Velcro to the halo vest. Now, halos are kind of falling out of favor with spine surgeons these days. They're very, very morbid. And honestly, if I was a patient or had a loved one that had an injury where it was halo versus surgery, I'd probably say modern day surgery is better than modern day halo right now. Halos have to stay on for about 3 or 4 months. They're very morbid, especially in the elderly population. There's actually a fairly high rate of mortality with halos, believe it or not, because these patients have such a difficult time mobilizing with them. But as far as what you guys have to be aware of, just make sure that they have a wrench that's Velcro to them in the very, very uncommon situation that you do have to abruptly take it off them.
Can they lay flat, or do they only can they only be transported in the seated position?
No, they can certainly lay flat. You know, there's times that we'll actually apply halos to small children that have significant spinal deformities. We don't do it much at upstate, but at some dedicated children's hospitals, believe it or not, children will be in a mobile halo. They could actually exercise in the halo. They can run around. You know, you'll see pictures of them in the swimming pool with the halo on, believe it or not. So you can actually be quite mobile with it if need be. Josh, any other questions that you guys have about this? I know we kind of blew through about 6 or 7 cases in a relatively short time period.
No, I think, I mean, I learned a couple things. I think the spine is an area I'm not so comfortable with, but I think you kind of opened my eyes to a couple other things going on out there.
I mean, I think you guys know best out in the field. You know, keep patients' blood pressure normal, make sure that they're well oxygenated, keep their spine in neutral alignment. I can't say that I've ever seen a disaster come in because you know, a paramedic or a first responder you know, did something wrong in the field. If a patient's deteriorating, it has nothing to do with anything that you guys have done. It's usually due to their index injury and the severity of it. So I think by and large, at least in upstate, I think all you guys do a fabulous job of getting patients to us expeditiously and, you know, with proper spinal precautions on a hard board and in a hard cervical collar.
Any other questions for Dr. Galgano? All right. Well, thank you very much for your time. Great presentation.
Yeah, you got it, guys. It was great being here, and thanks for having me, Josh.
All right. Thank you.
All right.
Now comes the fun part. Josh LeDuc, do you usually give any breaks when these guys are here so long? What do you think? Are we okay?
Every hour.
Are we currently in the bathroom? No, I'm just kidding.
Up, stretch, get the bathroom, recaffeinate. You know, the usual.
So we're good for 5 minutes, and I'll get my slides up. Does that sound okay?
Quick 5 minutes, since I know we just started a little bit later, but yeah, let's take a quick 5.
Sounds
Thank
good.
you for your time. Have a great evening.
It's like literally the end, but that's what I was laughing at. That's why.
My poker face is weak now.
Why is everyone leaving? Why is everyone leaving?
Seeing the game with Regina George and the Halo. That's all I could think of at the time. As soon as Kirsten said the Halo, I was like, I'm done. Like, I can't think of anything but Regina George right now.
This is what everyone does when they go on break. Everyone just disappears.
Oh, it's their faces that are gone. So people that don't have their cameras on, it disappears.
Yes.
I thought everyone was leaving. I was like, oh.
Well, that's
They're
aggressive.
gone. They're gone.
They're just like,
Jesus Christ. Who did?
He's already taken the program, I think, once or twice already.
I'm surprised I made it this far.
Singing.
Can we just take a minute? First off, where the fuck is my Amazon package? Out for delivery. Making popcorn. With my upstate water that was like frozen solid in the fridge. St. Joe's.
I went to St. Joe's and I didn't realize that they had shit.
St. Joe's. Their EMS room is packed.
We went there once and
Like
didn't even
Capri
see that.
Suns, seltzer waters, water. What else I had yesterday? Granola bars, fruit snacks, chips. Like St. Joe's, surprisingly, like of all hospitals, so they hate us.
Don't I purpose they were like giving out cups and
They
like,
hate us.
dinners and shit. I'm like,
Crocs usually does that. I haven't heard anything about it. It's usually at the Wednesday. I haven't heard anything about it.
My night one, so.
I want to be appreciated.
I still have my upstate EMS trauma shares from like 2 years ago.
Heck
You know what? Upstate didn't know about my sponsors last year and they didn't even give it to us. They just wanted to machine.
AVAC bought us all backpacks for some reason, and like they're not even orange or green AVAC, they're just like generic ass like small backpacks, and I'm like, I don't know what you want me to do with this.
We got dinners.
Yeah. Sorry, waves got even worse. They got breakfast
Woo!
and 10 gallons ice cream.
We're doing Saturday and Sunday because like nobody could like decide on which day we're doing their catering. I don't even know what it is. But I'm there both days, so
Food.
I'm already working both those days, so I'll be there.
I don't know.
Are you gonna come? You should show up.
I didn't know.
It's okay. No, but like,
That doesn't mean anything.
Was your late call at least worth it?
Code Black. So.
I said, right before she left, I said, that sounds like a code black call, because that's kind of like what I usually get. See you away. Yep. It's great.
There's a porter's house.
Oh, I had that a few weeks ago. It's disgusting.
It took more time to find him.
Yeah, we did one of those in Syracuse where literally the son broke into the house, walked over his father. He didn't know that he had fallen and knocked shit off and on top of him. And we didn't find him in the house for 3 days. We knew he was in there. We knew he was dead.
No.
We just couldn't find him.
Mine was a
Yeah,
lit
They literally had to start cleaning the house. And also they're like, oh, there's a body.
I had a naked mummified dwarf.
I fucking hate midgets.
A naked
Is this
mummified
mute?
dwarf.
This isn't muted.
That was fun. I went with Doug, actually.
They're scary.
Fun times.
My first
I
overdose.
was more worried about the dog that was so warm that I was ready to do CPR on.
The dog?
The dog, it was in front of the TV and it was like warm as that. It's like,
That's so sad.
don't tell me I couldn't. Who carried it? I have been laying in for a while.
I don't like my fingers buttery. You want to keep talking shit?
Buttery fingers.
Don't like them buttery. So yes, Andrew. I also do it for pizza and chicken wings. Anyone want to-
Oh, yeah, chicken
I do
wings.
chicken wings all the time.
Cheetos.
Yes.
I don't eat Cheetos. I don't like Cheetos.
I do wear gloves for chicken wings, I'm not gonna lie.
Well, butter my butt and call me a biscuit. So she doesn't like buttery fingers. Shut up.
You want some?
No, I'm like really full.
Anyone else want any? Since
My
I'm
stomach's
staring
gonna
at
hurt
you.
later from spicy food.
Josh, you
No,
want
we're
some?
staring at you wearing gloves.
To eat popcorn.
With the new mask
I do.
mandate starting tomorrow,
University has not changed their policy. However, we can go back to full 32 people in this room at one time capacity.
Is
but
that
we
why there's
have to
two
wear
chairs
masks.
at every table?
Yes.
Not that there's ever gonna be 32 people.
She said it not.
Hashtag fact.
Mandatory in-person.
Did you
Yeah.
get my email earlier about? My second toxicology case review, I sent it to you and Naomi.
Oh, yes, I did see that.
Perfect.
I have been teaching ACLS all day, so I'm like, oh, cool. I'm gonna ignore that. So I don't, so I don't touch it and then not download it to your file.
No, you're fine. Because I thought there was a way to upload it, but I couldn't find it.
No, I said it to email.
Okay. Okay. That was our wonderful Thursday afternoon.
Let me guess, you don't like those either?
Is there one
So
tomorrow?
actually, funny, ha ha.
Funny,
So
funny,
this
ha, ha.
one, I'm pretty sure they wanted me to shut the F up.
All right, fair.
because the first case, I was all over it because I was like, hazmat, I know it. And I was actually able to tell, because it was the Upstate Poison Center that actually ran it. And Dr. Coy Howard was in there, but we all had black screens except for them. And there was 4 people at the table. They never introduced themselves. But they, I got the hazmat vibe from the very beginning with the way they were presenting. I was like, is it CS? He's like, what's CS? And they're all looking at each other. I'm like, riot control? I'm like, riot control agent? And then I had to explain to them what I did prior to this, and it kind of was like an aha then.
Gotcha,
It was
gotcha.
pretty cool.
All right, Josh, are you back and are you ready, sir?
I think I'm here. It looks like everybody's kind of coming back. My co-presenter is here, I believe.
Hi.
So used to a dual screen in the office. One screen really throws me off. And I feel like I'm not going to be able to eat a chicken wing for a little while after some of Dr. Galgano's slides, but that's all good because they were really cool. I've been working with him for a while, and he's a great spinal surgeon. I thought he would give you guys some good information. So give me a thumbs up if you thought he was cool, or yeah, thanks. I thought he was pretty cool. He's kind of matured in his practice very quickly. A lot of spine people, spinal problem people are finding him for care. So his practice has grown very, very quickly, which is good for him. All right, well, I'll get started with some stroke talk, kind of, I guess, dovetails into what goes above the spine is the head. My name is Josh. I know a few of you, so hello virtually, and thank you for all that you do. Happy EMS week. Lots of things in May, but we'll celebrate you guys today with some stroke training. So I'm Josh. I'm a nurse at Upstate. I've been there for 12 years or so, give or take. I have a background in neuro. I love neuro, and most recently, I guess like 5 years now, I've been with the stroke world. So everything stroke I love and I appreciate. I also have with me Raisa Jovklaya, who I'll let you say hello as well.
Hey, so I'm the newest one back to Upstate. I started out in Upstate like 9 years ago in the neuro step down, and then just came back last summer to be in the stroke program. And I get to see my EMS folks that I got to be with back in the day in the waves years when I was like 15, I don't know, a while back. But I'm really, really excited to bring the two worlds of nursing and all you guys together. So happy to be here.
And we're looking forward to the next time we can come present in person, but I don't think we'll see this group for a little while. But you know what? Who knows where we'll be in a few years? We could be in the same spot with new information. But, we're going to cover a couple things. The A&P of stroke and what a stroke is really hasn't changed since you learned about it or we last talked about it. Pre-hospital care has changed slightly, and we'll cover that. And treatments are changing, quicker than they have before. Imaging and other, studies have been influential in stroke care. So we have some very aggressive treatments at Upstate, and I'll just kind of give you a couple cases at the end and kind of the future of stroke care, what you can look forward to. So obviously we're going to review facts, A&P. I'm not used to a dog as an office mate, so, we'll roll with that one. Stroke type, stroke mimics, what you'll see in the field, current treatments. We'll talk about large vessel occlusive strokes, kind of the big bad strokes that we can, get the most bang for our buck with treatment. And posterior strokes, the ones that we really have a hard time recognizing, both in-house in the ED with our providers, as well as in the field. We'll talk about the enhanced FAST-ED stroke assessment tool that we hope you've heard of, but we'll reintroduce if you haven't. And then we'll identify ways in which pre-hospital care can identify and influence stroke outcomes through some case studies at the end. We'll talk for about an hour, and we'll have some time for question kind of throughout to make sure you guys are comfortable and understanding and not really showing too much new to you. May is also Stroke Awareness Month. So we're kind of doing our due diligence to make sure that people realize that stroke is still happening to people. Every 40 seconds, someone has a stroke, which is crazy. Every 4 minutes, someone dies from stroke. It's a leading cause of short-term disability. And each year, it's probably more than 800,000 strokes because of COVID, but more than 800,000 people in the US have a stroke. We did see a little risk factor of COVID and stroke, and we can talk about that in a little bit. Not too much in Syracuse, but nationally. And most of the strokes come across as ischemic strokes, those blockages. We're going to do a little bit of anatomy, just a review of what's going on in the brain, kind of connects to the spinal cord. We have the cerebrum, kind of the front of the brain, so where most of our thought and excitement and activity comes from. Also, the biggest part of the brain that gets the blood supply. We're thinking about intellectual function, speech, motor, feelings, emotions, all that good stuff. And reminder that the left side of the brain controls the right side of the body and vice versa. I think you guys all know this, but when you're looking for symptoms, think of what part of the brain might be effective. And I did talk about anterior circulation, the blood that comes from the heart up through the neck and goes to the front of the head. A lot of blood in the front of the head. The vasculature of the brain, we know that the heart pumps a good chunk of its blood directly up to the head through the carotid artery and the vertebral arteries. They meet in an organ or structure called the circle of Willis, which is kind of a fail-safe within the brain. It allows for a blockage on one side and kind of the blood can shift around to the other if needed. However, that fail-safe doesn't always work. And when it doesn't work, we see stroke or aneurysm rupture there. And that circle of Willis is generally where we see the problem because most of the blood is being pumped through that feature. It gets a lot of use. Some terminology for you all. We have a left and right L/R middle cerebral artery, which is divided into the M1, M2, M3, and M4 segments. The M1 segment, kind of identified in the bottom right, is the thicker portion that comes right off of the carotid artery. It kind of spirals along at the base of the brain and works its way up to the circle of Willis. As you move out from the circle of Willis, the vessels get a little smaller and smaller. And if you can imagine a stroke at an M1 is really big. That's a large vessel stroke, and that will have a very big presentation to you in the field. If you have an occlusion at M4, you're talking about a very small portion. The patient might have a symptom such as I don't have sensation on my fingertip, or maybe one part of my body is lacking sensation. It might not even be noticeable unless you're a very trained neurologist. And we also have anterior cerebral artery, posterior cerebral artery, and the internal carotid arteries. And here's just some cool pictures of what they look like with some colors. We also have to think about the back of the brain, the cerebellum. This area, although small, is responsible for quite a bit of important activities. It's the second largest area to the cerebrum and receives the second amount of blood flow. The tissue in the back of the brain is a little bit different than the anterior tissue, and stroke treatments are slightly different there. Like I said, posterior circulation strokes are harder to recognize, and they'll present with sudden onset vision changes or field cuts. If you've ever heard of a field cut, it's where somebody can no longer see out of one portion of their eye. Eye movements that might not be congruent or equal with each other. Sudden onset is the key here. Any loss of consciousness that's sudden onset, sudden changes in tongue movements, swallowing trouble, coordination and balance are the big ones. So you can see that I have eye movement and coordination and balance as the largest, most bolded items here. And those are how they present. These patients will often drive themselves or have someone drive them to our ED and walk in through triage because they think something else is going on. I mean, this looks and sounds like vertigo. I get vertigo once in a while and I don't think I'm having a stroke, but I always think about it because I'm crazy. But these patients will present like that in triage and they'll present themselves that way as well. So just keep that in mind as we roll through the rest of this. The blood flow to the back of the head is going through your basilar artery or vertebral artery, which both can become occluded in a similar fashion. We consider these large vessels as well. Let's see. We know that anterior circulation, again, presents with large presentations, so that big facial droop, the arm or leg weakness, or speech trouble, and the posterior circulation, coordination changes, and balance issues, and eye deviation. I'm just reiterating kind of what I talked about. Those are the big takeaways for those. Most of the patients present as an anterior or front circulation stroke, and the smaller percentage are presenting in the back with posterior circulation. So pass to Raisa.
Hi. So what is a stroke? It's basically just an interruption of blood flow to the brain. It could be caused by blood or, clot or a blockage of some sort. So we'll go with the first comment. We'll go to the next slide, Josh. There we go, interruption of blood flow. So TIAs, we've actually been seeing a lot of TIAs recently, but these are warning signs to an actual bigger stroke that causes permanent damage. This is basically, think of it like a blockage going through your vessel and it's causing symptoms, but then it goes away on its own. So it already just shows that this patient has a precluding factors for an ischemic stroke. So with these patients, they'll often call, you'll get a stroke call, and they'll say, I had, the right side weakness or whatever symptom they had. And by the time you get there, it went away. Well, you should still pre-notify for these patients because basically it gets our team ready and we're basically showing, getting that full stroke workup done for these patients, which they need. So we want to prevent a bigger stroke, which is on the next slide. And this is an acute ischemic stroke. The next slide. And these are the most common strokes. So this is permanent damage. You'll have those symptoms. Think about that fast facial drooping, unilateral weakness, the slurred speech, changes of vision or balance, eye deviation, denial or neglect. And these are caused by either a blood clot going around somewhere in the brain through the vasculature, or a blood clot is formed and is blocking blood to a certain part of the brain. This is the most common, like I said. And it is often happening after a TIA. The next one, we just want to talk about time is brain. So when the blockage is happening, every second count, like millions of brain cells are dying, and any second that we can save is going to save that person's function in their brain. So you want to get them to the hospital as soon as possible. This is why we pre-notify. This is why we get the team ready. This gets the whole team ready so we can do TPA or thrombectomy. Those are the gold standards of treatment. So with TPA, we have a window of up to 4.5 hours after last known well. Some cases can be beyond that, but those are very special cases. And then the other treatment is thrombectomy, and this can be done up to 24 hours or more based on imaging. So we really want to make sure that we give these people the chances for either one of these treatments.
Raisha, quick question.
Yeah.
The 4.5 hours, is that the start of the TPA or the completion of the 1 hour infusion of TPA?
So the TPA, like, I don't understand the question. Just repeat that one.
I think it's the start you're talking about.
Yeah, because it takes an
hour
hour for the TPA infusion to go in. So I was wondering if that hour of the 4.5 time frame was included in giving the TPA fully.
It's the bolus, the start.
Yes, you want to give it within that 4.5 hours.
Okay, cool. Thanks, guys.
Yeah. Good question. So besides ischemic strokes, we have the bleeding strokes, hemorrhagic strokes, and those can be caused by bleeding inside the brain tissue or outside the brain tissue. So it's either intraparenchymal, think of intra, inside, or subarachnoid on the outside of the brain. So we'll go over those in the next couple of slides. And intraparenchymal or intracerebral usually is caused by those patients that have chronic high blood pressure, and it weakens their blood vessels, and they usually come with like a major headache, and these people can go down pretty quickly. They can lose their levels of consciousness, and even furthermore, by the time they have pupil changes is pretty serious. But with these one too, time is brain also, but in this case, you just need to get them so that they can have any kind of like decompression for treatment, not TPA or thrombectomy. So with the next cases, we have subarachnoid hemorrhages. These are pretty common also, and they're usually caused from an AVM rupture or an aneurysm. And these people, they'll present like, they'll be very sensitive, they'll be curled up in a ball, they have the worst headache of their life. It's usually that sudden thunderclap headache. They don't want to be touched, they don't want to be bothered. And these people can get treatment. Actually, they can do actually pretty well. You'll get these patients, and on the next slide, we'll see a coiling treatment from a ruptured aneurysm. So, they'll have a subarachnoid hemorrhage, they'll bleed inside the brain, and we'll do an angiogram. You guys won't see this part, but if they find an aneurysm, they can coil it. So you can play that video. And these coils just get packed into that little ball to prevent, further bleeding, basically occlude that aneurysm pocket. and some of these patients can have like 7 or 8 coils put in, depending on how big that aneurysm is. So it's actually pretty cool. There's also clipping too, but these are, they find these work pretty well, and it's less invasive. With clipping, you got to do a surgical procedure, whereas these are basically you just go through the groin, like, you know, like a cardiac stent would be done, you know, through the groin. So it's pretty cool. We want to remember too our stroke mimics, and these often present with a positive CPSS score. So you don't want to make that judgment call out in the field. So if they're a positive CPSS, you do want to pre-notify, because you know, they can present with a hypoglycemia or hyperglycemia, hypoxia. They can come from a fall and have like a, you know, concussion, or they have a migraine or a complex migraine, or Bell's palsy is another common one that will look like a facial droop, eye droop. And they'll present like a stroke, but they end up not being a stroke. You don't want to rule that out in the field. You want to obviously gather all your data, but you want to still pre-notify so that they can get the full stroke workup, all the imaging required to figure out if they're actually a stroke. And any questions on anything in regards to the ischemic stroke, bleeding strokes, what we do for treatment?
I was just looking at the chat. You know everybody everywhere, Ray. So it's popular.
Well, there's an overlap.
I do want to say, Raisa pointed out that we have seen a lot of TAAs lately. And stroke is stroke is a diagnosis by exclusion. So you have to figure out everything that's not going on before you can think it's a stroke. So you rule out, you know, hypoglycemia, all the other things that could be mimics that Raisa just talked about. And then when you have nothing left, you say, this could be a stroke. Because remember, your CAT scan should look fine if it's an ischemic stroke that doesn't have any changes. So you have a normal CAT scan and you have a last known well that's within the window, no other mimics, you treat it like a stroke. And then that MRI that you get within the first day of your hospitalization will say, yes, there is stroke, or no, there's not. And oftentimes, if there's no change on the MRI, we will call it a TIA because the patient had symptoms. But we've been calling it, you know, stroke aborted by TPA, and that comes out on the discharge line, which is interesting because the coders are seeing what happened in the hospitalization. They're saying this patient had a stroke, but the thrombolytic broke it up, and that's pretty impressive. So TAAs are definitely tough. Patients also walk in with TAAs to the triage, and we as a stroke center are responsible for treating a TAA just like an ischemic event. That's why it's so challenging, because they have the same metrics. They have the same requirement pre-hospital, so pre-notification. They have the same door to CT time, door to potentially thrombolytic time. Even though their symptoms are resolved, we still want to make sure that they're giving the same treatment in case there's an ischemic event going on. Does that make sense? It's hard to act on something that you don't see, and it's hard to teach people that they should have done it when the symptoms are gone. So I think, and correct me if I'm wrong in any conversation, if the patient complains of it, consider it in your differential for bringing it to the doc's attention when you get to the ED. Just mention it, and then we can do what we want.
Believe it.
If the patient states it, even if you don't believe it.
I was going to say we had a couple misses last summer where the patient actually was like, I think I'm having a stroke, but the symptoms were gone or they were very minimal, and they ended up actually having a stroke. So patients know. Some of them might, you know, they might say everything's a stroke, but just keep that in mind when you're seeing patients out there.
All right. Any other thoughts, questions on that? We'll move on. We built this slide deck for those who have to go to the bathroom a lot. No, I'm just kidding.
Me and Josh.
Yeah, sorry. We drink a lot of water. This is a fun group. We can talk about it. All right. So what are we doing for these patients, and how are we figuring out what's going on in their head? So obviously we can't do an EKG of the head. However, it's, you know, people are trying to invent these helmets that may be able to detect decreased blood flow, but we're not going to see that in anytime soon, I don't think. So we're stuck with the CT scan. And, you know, over the last 5-10 years, CT scans have really increased their quality. At Upstate, we have 4 scanners available for ED patients or inpatients, and each year they get better and better. We have put in a bid for a portable CAT scanner, which we'll keep for our in-house patients that can't travel because they're unstable to a CAT scan. And so really cool. The scanners are getting smaller. They're going into mobile units that go around pre-hospital setting. And like I said, they're getting better graphics. What has changed for the CT scan is the type of image that we can do. So we can do and I'm going to talk about this a little bit more, but based on what your scan looks like, your treatments are completely different. So the slide on your left is obviously a hemorrhage. You can see that kind of, I don't know, Florida shape, whatever it might be. That's a bleed in someone's head. And on the right side, you see a little bit of a large vessel occlusion, but otherwise a normal looking stroke. The slide on the left, the scan on the left is treated very differently, surgically or medically. They might go see Dr. Galgano for a cranie. They have a lot of pressure backing up in there. Whereas the slide on the right could be an ischemic event treated with thrombolytic or interventional radiology, that clot retrieval. So we get a lot from that first scan, and that's kind of the most important thing that we can do for the patient besides a good H&P. So I think I've talked about this with several of you, but we're very comfortable talking about STEMI of the heart. We understand large vessels of the heart. We know the widowmaker, we know where clots form in the heart and what they do. But let's think of the brain similar to the heart. I think it's more important. And let's consider a large vessel stroke kind of a STEMI of the brain. So we have large vessels that I mentioned come off the carotid artery, and they break into the M1, M2 of the circle of Willis. Those obviously can become blocked very easily from thrombus flowing off from the heart or otherwise in the bloodstream. And when they do get blocked, we see big problems. So how do we pick those up on that first CAT scan? How do we know what's going on? So what has changed? We can do CT angiograms very commonly, and at Upstate we do it as first image 99% of the time to rule out large vessel occlusion. And what you see on the slide on your left is a CT angiogram of the head. Requires IV contrast, obviously through an IV, and an injection that highlights the vessels. And the area that's circled, if you compare it to the other side of the head, you can see they're not the same. There's blockage, and the spaghetti is not continuous to that. That's a large vessel stroke right there. So imagine there's a clot in there that's blocking the blood and dye from passing through. And what you will see is nothing. You'll see a blockage of the vessel that's different. This will present with symptoms that are contralateral. So this will be the right-sided symptoms, and it will kind of match when you start to see the picture and the patient all together. What you see on the right side is the CT perfusion, a very colorful image that's telling us how well the brain's perfusing. And this is really where the most advancement has come in stroke care. 2018, there were 2 trials released. Upstate had a couple patients that were participating in them, which was cool for the patients because they got treatment that was kind of abnormal but did well for them. The Dawn and Diffuse 3 trials were the 2 that came out. And basically they validated thrombectomy, that clot retrieval, up to 24 hours after last known well. And they did this with CT perfusion technology. So if we look at the brain and think of what's happening during a stroke, if we have blockage, the brain starts to die. And when it's dying, it's not getting the same amount of blood flow. The area that's around the dying brain is what we call penumbra. That's getting less blood flow, but enough to survive, but causing symptoms. So we really want to try to treat that penumbra and try to save the penumbra. The ischemic area is not going to come back. So let's see. So we do our CT perfusion, and we at Upstate use what's called a rapid CT processing. Rapid is a software that's cloud-based. The images go up to the cloud and they're processed, they're colored, and they're given a value. So we have on the left side of your screen, CT perfusion that shows ischemic core, so which is cerebral blood flow less than 30%, and it gives us a volume. So 73 mLs. It's saying 73 mLs of this person's brain is dead. On the green side is the area that's saying this is penumbra. We have 167 mLs that's potentially salvageable. So what we do is we subtract the 2 and then divide the 2, and we get a mismatch ratio. So if the ratio is greater than 1.6, this patient's a candidate for thrombectomy, clot retrieval, past that normal 6-hour window. So we've seen patients kind of qualify for thrombectomy, not time-based anymore, like thrombolytics, TPA, but more so imaging-based. And I think I'll touch upon this a little more later. The future of stroke care is really image-based, and we're going to see some changes with TPA and thrombolytics based on what imaging looks like. Patients that have favorable CTAs that show clots or CT perfusion that show that mismatch that we just talked about can go on to have a mechanical endovascular reperfusion therapy, or IR. Lots of names. And we're going to show you a video real quick. I can't remember if this is narrated or not, so if it is, I'm going to stop talking.
Position the balloon guide catheter as close to the thrombus site as possible. Connect a rotating hemostatic valve, or RHV, to the fitting of the guide catheter, and then connect the continuous flush. With the aid of a suitable guide wire, hold the guide wire in place and advance the microcatheter. Position the microcatheter distal to the thrombus so that the usable length portion of the solitaire FR will extend past.
Front row, Raggy.
Josh, did you break it?
Sorry, you can hear that too, right? I was muted, I'm sorry. Okay, I just want to make sure you understand what you're seeing. So this is that clot in the large vessel in the circle of Willis. And this is in the IR suite, the doc is going through the groin like a cardiac cath to get the device through the thrombus, and they're going to pull it out. So I'm gonna let the video finish.
Each side of the thrombus when fully deployed. Once the microcatheter is in place, remove the guide wire and tighten the RHV to secure the catheter. With the aid of fluoroscopic imaging, carefully advance the solitaire FR until its distal markers line up at the end of the microcatheter. To deploy the solitaire FR, loosen the RHV. Then carefully withdraw the microcatheter while holding the solitaire FR in place until the microcatheter tip covers only the proximal marker of the device. The usable length of the deployed solitaire FR should extend past each side of the thrombus. Tighten the RHV around the microcatheter. Angiographically assess the revascularization status of the treated vessel. Inflate the balloon of the guide catheter to occlude the vessel. To retrieve thrombus, slowly withdraw the microcatheter and solitaire FR as a unit to the guide catheter tip while applying aspiration to the guide catheter.
So pretty cool. And obviously that would be done under kind of fluoro. So you would see the vessels lit up just like an X-ray, and you can kind of see that like a fluoro movie. It's really cool to see. Let's see. So obviously, patients that have these large vessel occlusions present very similarly. So if you have a left MCA, that big vessel on the left side, picture your left side of the head will affect the right side of the body. So our language center is generally on the left side of our brain, unless we're right-handed. Sometimes it switches. So if you have a left-sided stroke or occlusion, we'll probably see speech impairment or lack of speech. Sometimes there's language issues where they might not be able to connect things or lack of comprehension. A left gaze preference. Patients tend to look to the side of the problem. So I look to the side of my stroke. Similar, if I had a tumor, I would stare at my tumor and say, look, I got a tumor over there. My face would be drooping on the right side, and I'd have a right side weakness or plegia. On the opposite, if I have a right-sided stroke, I might have slurred speech. Remember, my speech center is over here, but this side does kind of help out the left side if it gets, has some trouble. So slurred speech, a maybe. Left-sided weakness, a right gaze preference, left facial droop, and left side neglect. The right side of the brain is really helps me understand where I am in space and that I'm connected to my own body. And when I knock it out, I sort of lose that. So if I have a right-sided stroke, it can have a lot of problems for recovery after that go beyond just that flaccidity. I might not ever know that my left side of my face is my face to shave. So we see a lot of strange things with right-sided strokes, unfortunately. Brainstem strokes or that cerebellar stroke, like I said, difficult to see, abnormal eye movements or field cuts where half my vision can suddenly be lost, nausea, vomiting, ataxia, vertigo, difficulty speaking or swallowing, decreased alertness or consciousness, or cross-signed. Anything that doesn't really make sense for the typical stroke could be a posterior type stroke. I would say watch for that vertigo and ataxia first, and then as you don't want the cerebellum to start to swell or stroke, but as it gets a little bit worse, the patient's consciousness will decrease. So if you hear a presentation that they were dizzy or were nauseous and dizzy before passing out, put those signs together. This could be a posterior stroke. And the treatment is the same, but a little bit different time window. We've seen some really interesting posterior strokes altogether are interesting, but posterior strokes, really some interesting things. Has anybody heard of locked-in syndrome? It's really kind of sad. The patient is completely aware of everything that's going on, and they lack all movement, including breathing, except for, I think it's a lateral eye movement. It might be a vertical, I'm sorry. But that's all they can do to communicate. And I remember a couple cases, I've had 2 in my life that I've seen. Obviously the details and the ending are not great, but they can be prevented. So if you look for these signs that can be subtle and put stroke in your differential, we might be able to save these people from kind of a rough fate. But occupational therapy and physical therapy are really instrumental in stroke recovery. Once they're medically stable, really helping the patients realize how to function again in their new body and their new brain. Stroke is like if your electrical panel in your house gets shocked, everything's got to figure out how to do it. You have to get rewired. And these patients can generally recover somewhat. They have to relearn, and kind of neuroplasticity is a hot topic, reteach their brain how to connect things. So they'll never be the same. And that's a lot of frustration for patients. They want to be the same as they were. Can't blame them. If I couldn't move my arm as well, I'd want to be the same also. So post-stroke depression is something that we also see a lot. And I'm glad that Mike Galgano didn't see this. We have seen a good number of patients that go for the chiropractic adjustments that either had a problem already in their vertebral artery, maybe a thrombus that a neck twist will loosen, or some tissue changes within the vertebral or basilar arteries. We have seen those, and unfortunately they happen, but they are fixable. Some dissection back there. Questions or thoughts from the group so far? Any firsthand experience with posterior strokes, or any neat or sad or good catches that the group's had so far?
My father had one a couple years ago in the cerebellum. But
cerebellar stroke.
Yeah, he had the vertigo and vomiting and everything. He just, all of a sudden, he was working and then he felt like the room was spinning. And so ended up being like a couple millimeter stroke. But he's fine now. So.
He's without symptoms now?
Yeah, he's perfectly fine. He just still is on Coumadin.
Did they give him thrombolytics? You don't have to tell us, but.
No, because they didn't actually find the stroke until the MRI the next day.
Mm-hmm.
Okay, all right. Well, I'm glad he's recovered. That's really good to hear. And he's on a blood thinner. You want to try to prevent secondary strokes if possible for these patients. So that's good. Anybody else with any different experiences?
Yeah, during ER time, 40s male came in and he had only experienced about 15 seconds. And Brianna, this is your patient, so you can chime in, of just like he missed his mouth with a coffee and some slurred speech, but everything resolved itself and got him to CT within like I believe it was 36 minutes, and they actually found that he had a stroke, but he was completely fine for the entire duration that he was sitting in the ER. And when I looked at the nurse I was following around, we both kind of had this dumbfounded look when the doctor told him, like, really? But they found it, and he was fine. Yeah,
some people's brains, like for the heart, a general rule of thumb is the older you get, the more collateral you get. You can survive a heart. Like if I had a heart attack at 40, I'll say it, I'm almost 40. I might not do well because my brain hasn't conditioned itself to have collaterals. The brain is sort of similar where it can have collateral circulation that might help it recover itself from stroke, where a younger patient might not as quickly. So we do see that where patients last known well is, 2 hours or 3 hours or something where you're like, great, we got them here fast, we're going to give TPA. But then you do your CAT scan and you're like, oh, really? There's already changes on there. They already had a stroke. So that does happen, unfortunately. More often than not, it doesn't, which is good, but we do see it from time to time.
I mean, this was right when his coworkers noticed that he had him, they immediately called. Like, this wasn't there was no a lot from when the time it happened to his CAT scan and all that stuff. It was all within the window.
Sometimes they also will find a stroke that's happened days ago that the brain change is now affecting the patient now. So if you have a small enough stroke, remember, it might only debilitate part of my finger. I don't use this part of my finger often, but if I pick up maybe a chopstick, I would drop it and say something's off, get my CAT scan, and it would say stroke. But it could be, much older than when I noticed my symptoms. We see that occasionally as well. But that's definitely an interesting story. Anything else to add from the group?
I'm high risk for stroke, and this is terrifying and interesting at the same time.
Sorry. I know Dr. Galgano's, I bought an old Wrangler last summer, and I feel like I don't want it anymore after hearing him talk about things. But a risk that we're willing to take. Well, I hope that you, I didn't catch your name, but I hope
It's Maggie.
Oh, Maggie, I hope this gives you some information. You know what to watch for. And if your family's aware of your risk factors, that this can go high up on your potential differential. I hope we don't ever see you. But this is give you a little more information. I think I'll give you back to Raisa for a minute.
Oh, hey. So you guys are familiar with stroke scales. I know, sometimes you guys use a few. There's always a new one that comes out, but the most common ones are the CPSS and then the FAST-TD. So the CPSS, while it's great because it does catch the majority of strokes, those anterior strokes, because you're looking for that face, arm, speech, you get one or all three of those, and you pretty much got yourself a stroke. And then what we teach the community is that FAST, FAS, the CPSS, and then we add time to call 911. So it's just easy, interchangeable to teach to everybody. But the problem with the CPSS is that we kind of miss those posterior strokes, the ones that are harder to catch. So that FAST-TD scale, so the FAST-TD score, on the next slide, it includes eye deviation and denial or neglect. And those two are one of the key factors for not only posterior strokes, but indicative of a large vessel occlusion. And the good thing about finding those large vessel occlusion strokes is with large vessel occlusion, we can do a thrombectomy where we can get that occlusion out. And these patients can literally change right on the table. You get that clot out and they're already like talking and looking around like, what's going on? Why are all these people around me? Josh popped right out, I think. We'll wait for him to get back on. I think it actually kicked me out earlier.
I literally didn't touch anything.
Josh,
your meeting is cursed.
It happened.
All right, just give me a second, folks. Yeah. Sorry.
That's all right. But yeah, the FAST-TD, we're actually tracking it too. I'm looking because I review the PCRs of all their stroke patients that come in, and I'll mention it later. But I'll show you. We'll get to it, I guess. So yeah, FAST-TD, the eye deviation, vision changes, denial and neglect, and dizziness. Usually we just see the denial and neglect, but we added the dizziness to it. And that's why on our end, we kind of called it the enhanced FAST-TD tool. And on the next slide, you'll be more familiar with the FAST-TD scoring system. So yeah. So, this is why we do it. We look for the posterior strokes. We catch those LVO strokes, large vessel occlusion strokes. So you'll get a score. I think it's If it's 4 or greater, it's usually indicative of a large vessel occlusion stroke. So that's why the scoring is great. I don't know how it is. I don't always see it on the PCRs, even if they're used. So I don't know how often you guys are using it exactly, but on the next slide, this talks more about the enhanced FAST-CD tool. So on top of the scoring system, the enhanced FAST-CD, this is just kind of like a tool to kind of help catch those LVO and posterior strokes. And this was a video that was produced as a regional educational effort and quality initiative to help EMS obviously identify those LVO and posterior strokes. They were just finding every hospital struggles with this, every place struggles with this because those posterior strokes are really difficult to catch. So we're just trying to bring awareness to that and just trying to find different ways to catch those kind of strokes. So we can play this video. I'm really proud of it. You guys have probably already seen it, but we can play that. It describes it pretty well.
A stroke can happen anywhere in the brain. Not all strokes present the same. It's important to know the symptoms in order to identify all strokes and to avoid delay and ensure prompt care. Current guide.
And you guys hear that okay?
I can hear it, yeah.
Yeah, okay, I'm gonna let it go then, sorry.
And suggest the use of a stroke assessment tool such as FAST-ED for identification of additional types of strokes beyond the Cincinnati Pre-Hospital Stroke Screen. Let's explore 2 very different possible patient scenarios. Peter experiences a sudden loss of consciousness while at work, and a coworker calls 911. EMS notices evidence of an obvious large left-sided stroke due to the severity of the symptoms using the Cincinnati Pre-Hospital Stroke Scale. They give pre-notification to the hospital, and the stroke team is immediately activated upon their arrival. A CT scan and CT angiogram are done first, showing a large vessel occlusion. A large vessel occlusion, or LVO, is a cerebral occlusion in the internal carotid artery, ICA terminus, middle cerebral artery, M1-MCA, vertebral artery, or basilar artery. A CT perfusion scan is done next, showing that the patient is eligible for a thrombectomy. Alteplase and thrombectomy treatment for stroke is begun without delay. Robin is experiencing a posterior stroke and calls 911 complaining of sudden onset dizziness and blurred vision. EMS uses the Cincinnati Pre-Hospital Stroke Scale, but no stroke is identified. She is brought to the ER without a stroke alert or stroke team activation. Instead, Robin waits in the ER area for triage. As her symptoms progress to confusion and slurred speech, a stroke evaluation is prompted. A CT scan is done showing a completed posterior stroke. Therefore, Robin is out of the window for treatment. Delays in stroke identification can lead to a bad outcome. Let's take a look at the facts. More than 1/3 of posterior circulation strokes are initially misdiagnosed. Ischemia is when blood supply to a part of the body or organ is decreased. Ischemic strokes comprise 87% of all strokes. And of those, 20% are posterior strokes. The 5 most common symptoms of posterior strokes are dizziness, unilateral limb weakness, dysarthria, which is difficult or unclear articulation of speech that is otherwise linguistically normal. It can be slurred, slow, and difficult to understand. Other symptoms are headache, nausea, and vomiting. It's most often a combination of 2 or more symptoms rather than just one. Stroke is the leading cause of disability. Patients who arrive at the emergency room within 3 hours of their first symptoms often have less disability 3 months after a stroke than those who receive delayed care. In the United States, around 795,000 people suffer a stroke each year, and someone has a stroke every 40 seconds. Every second of an ischemic stroke, 32,000 brain cells die. And every minute that number jumps to 1.9 million brain cells. So what is the Enhanced FAST-ED tool? It's a new assessment tool to help identify the strokes that are often missed. Since we're all familiar with the FAST acronym, the ED will help trigger the identification of both large vessel occlusions and posterior strokes that are often missed, as these symptoms can be sudden onset. F is for face. Have the patient smile and show their teeth, since showing your teeth involves more muscle movement and can help truly identify a facial droop. A is for arms. Have the patient raise both arms at the same time with palms up to the sky in order to identify arm weakness or drift. S is for speech. Is the speech slurred or absent? Listen to the patient's responses and ask orientation questions. T is for time or terrible unexplained headache. Call 911 with no delay. Identify the last known time the patient was well, with the help of the patient, their family, or witnesses of symptom changes. E is for eye deviation or vision changes. Is the eye gaze deviating to the left or right, or are the eyes not moving together? Is their vision blurred? Look for nystagmus, which is rapid involuntary movements of the eyes, and check for identification of objects. D is for denial or dizziness. Does the patient have disregard for one side of the body or unrelieved dizziness? Watch for neglect of a body part. If the patient is disregarding or not noticing the other side of their body, and ask about sudden dizziness or how and when it started. All of these symptoms can come on suddenly. Now let's rewind and try this tool on our 2 patients. EMS asks Peter about his symptoms using the FAST ED tool and identify that he is experiencing numbness on the right side of his body. They promptly call in a stroke team activation to the hospital. When Robin tells EMS about her dizziness and blurred vision, they recognize these symptoms from the FAST ED tool, prompting a pre-notification to the hospital in order to rule out stroke. The stroke team is activated upon arrival, and Robin receives prompt stroke care. This time, Robin is able to receive alteplase and ultimately a better outcome. Let's follow the stroke code pathway from start to finish. Start with a pre-notification to the hospital as soon as possible. Do not delay. A stroke team will meet you upon arrival at the ER doors or triage. The stroke team will then perform a neuro evaluation followed by a CT scan and treatment options such as alteplase and thrombectomy. When dealing with a stroke, time is of the essence. Understand the importance of the enhanced FAST ED stroke assessment tool in order to identify all strokes to avoid delay and ensure prompt care.
What do you guys think? This video basically just shows how, gives you 2 scenarios, how in one scenario, obviously, because we missed the ED, those posterior symptoms, this patient had delayed stroke care, which oftentimes happens. And not only our case, but this has to be stressed all over the place. But obviously you get treatment fast, you get a better outcome. So how can you guys help? On the next slide, obviously, we always, make it a big deal about these pre-notifications, but they really make a huge impact on these patients' care, literally from the doors, from when they enter the hospital to when they get to the neuro unit. But when you guys pre-notify, we get a page out to the entire hospital of all these teams, like the neuro doc, ED doc, of course, gets the call. Go back, Josh. And the neuro SWAT nurse that meets the patient and you guys at the door as well. I know you guys get like a bombarded amount of people when you guys get in, but everybody gets activated. We get the team ready, the CTs ready, and the floors are ready for a possible stroke patient, The other thing, it's obviously a DOH requirement as well. So not only do we require it, but DOH requires it, and we also, a big reminder to document it on the PCR. Sometimes you guys pre-notify and then it's not documented, so you kind of lose credit on that end. But like I said before, even for those TIAs, those patients that have stroke symptoms and then they resolve, or the patients that report that they had stroke symptoms and the symptoms resolve, pre-notify for those. The worst thing that can happen is that they get to the door and the doc evals them and he's like, I don't think this is going to be a stroke, but you did your part, and that's what we expect. A big thing about the last known well, we really want to make sure that you guys can get a last known well for the patient or family or whoever's around to try to get an accurate last known well. That's usually the biggest delay when we're trying to figure out if we can give TPA, just to try to determine an accurate last known well time. So if you guys can get that information for us, it helps a lot. Obviously, when you guys are in the rig, you're getting an EKG. If you see an AFib or arrhythmia, this could be indicative of a cause for a stroke, which is also helpful. You want to get a blood glucose because we want to rule out those stroke mimics. And getting 2 large bore IVs above the wrist, this helps to prepare for these patients that are going to get a CTA, which sometimes we actually do. We obviously do a CT scan, but sometimes they go ahead and do a CT with contrast, and that gets the vessels and the blood flow and everything like that, rather than just a CT scan to rule out for a bleed. And of course, you do the regular H&P with allergies And so anyway, when we get to the doors, you meet the team and you prepare to go straight to the CT scan. As you can see on the next slide, we have a really small time window. So everything's timed from when you guys enter the doors, from when the doc meets the patient, from when they get to the CT scanner, from when the CT scan results are read, to when they get TPA, and also the same case with those thrombectomy patients. Everything is timed. So things are constantly having to be moved. So anytime that we can get the team there, it does help with that stroke pathway. Now, I don't know if on the next slide, we talk about IV TPA during transport. I don't know if you guys transport a lot of patients with TPA, but this would be a case where you're transporting a patient that got TPA at a local hospital, and then you're bringing them to another, and TPA is still infusing. So when TPA is infusing, there's a lot of frequent vitals and neuro checks during those first 2 hours. I would just say do the Q15 or Q30 just to be safe. It's usually within that short time period that these patients are getting transferred. These patients can have neuro changes pretty quickly if they have a hemorrhagic conversion. And of course, if their blood pressure rises, over that 180, this is why we have that rule of keeping it less than 180 when they're having IV TPA infusing. Obviously, if someone's blood pressure, goes through the roof, they could have a bleed, or it's probably a bleed that's happening. Obviously, there's a low chance of this, but we want to watch out for that. At the end of the day, always use medical control for guidance, though, with these patients. So we'll move it over to Josh.
I think what's really cool, TPA has been around since 1995. The dose hasn't changed, but some of the things that we can see, kind of a foreshadowing, thrombolytics. So alteplase is, when we say TPA, we mean the drug alteplase, but also in that same category of TPA, tissue plasminogen activator, is a drug called tenecteplase. And you've probably heard of that for cardiac patients. It's been used for a while for any cardiac thrombolytic, but it's sort of becoming a little bit more popular in the stroke world. We're still waiting for real solid guidance on the dose and what time to use it, but at Upstate we've started integrating it into select patients. So generally you would want to have a patient with a large vessel occlusion and last no while less than 4.5 hours. It's still the same time window, and you can give them tenecteplase. We've dosed out 3 doses this year. And we're looking to make it a little more frequent. I'm still waiting for the American Heart Association, American Stroke Association to tell us that we can use one or the other. They're still on the camp that it's non-inferior to alteplase, so we're getting there. But alteplase has been the only drug on the market for stroke thrombolytic since 1995. But in case you were curious, tenecteplase and alteplase are both made by the same company called Genentech, and we wish we had stock in that company. Tenecteplase is significantly cheaper, and tenecteplase is given as a bolus only. We say bolus and go. So alteplase is a bolus and then an hour infusion. So these patients that are coming from the North Country or from further away generally have to have a nurse or critical care certified or paramedic level that's trained with alteplase to ride along. The tenecteplase bolus and go, the patient can get it in the ED and then move right along. Obviously, there's still the same considerations for post-thrombolytic blood pressure. You want to monitor them closely. They're still at risk for bleeding, just like alteplase. So I don't think any of our area hospitals are using tenecteplase for stroke, but if you do end up transporting a STEMI patient or cardiac patient that's received tenecteplase, just keep in mind it can also affect the head. Treatment time window for thrombolytics based on MRI. There's been a couple studies recently. Wake Up is one of them. And using MRI in a specific sequence of MRI, they look at the brain tissue and they kind of compare, similar to that CT perfusion that I showed you, compare what's called a flare, kind of the swelling of the brain versus possibly the area that's dying or getting less blood flow. And you can extend thrombolytic window based on the MRI. We're not doing this often, but what this means is that if you bring a patient in with a last known while of greater than 4.5 hours and our docs are saying MRI, let's see if we can give them TPA, we might actually be giving them TPA beyond 4.5 hours based on this MRI. It's rare, we're doing it more. And it generally requires not only an MRI, but a conversation with the patient and or decision maker, and usually will have a pretty strong consent or solid note that explains the risk benefits. The patient can deny this. It's not standard of care, but it is an option that may become more popular in the years to come as MRIs get better as well. Portable CAT scanners we talked about, obviously can go to the patient if they're already in the hospital. Mobile stroke units are out and about in a lot of the major cities. Rochester is the closest one with a mobile stroke unit. They're driving all over in New York City, competing and hitting each other. Not really, but within the mobile stroke unit, they have a portable CAT scanner. They can pick a patient up, give them a CT, a CTA, and CT perfusion, and then dose out the TPA or thrombolytic while the patient's coming to the hospital. So obviously, the patient receives a quicker treatment time if they're picked up by a mobile stroke unit. That's obvious. I'm still waiting for evidence that we should have one in Syracuse. My medical director wants one. Your tax dollars would buy it, and I'm trying to make sure that we don't buy one unless we're really sure we could use it. You guys do a fine job getting your patients to the hospital quickly, and I think that's probably better than a mobile stroke unit that's zipping around the Syracuse metro area. And secondary stroke prevention, we're in a world right now where we really focus on fixing the problem after it happened because we make more money. If we were living in a different country, primary prevention would be key. They would be doing, free screenings. I turned 40, I get all my labs done for free. I know my risk factors. Instead, I have to advocate for myself and really ask for these things. But secondary stroke prevention, if the patients come in with a stroke, we're really going to work them up. We send every patient home. I won't say every because there are some strokes where we cannot figure out why they happened, but we send most patients home with a why they had a stroke and an answer of how to present another stroke. A lot of times it's anticoagulation. We might do some carotid clean outs if there's any occlusions there, or if they have AFib, we might give them some drugs to help with that. But really secondary stroke prevention. We don't want them to come back. I personally feel that we failed the patient if they come back for a second round of stroke. I feel really bad that we missed something. It doesn't happen often, but it shouldn't happen at all. So really that's kind of the focus of what we do at Upstate with our discharge process and making sure they get the care that they need in the transition back to home. So they're going to go home with disabilities. We only keep them in the hospital for 4 days on average with a stroke, and that's super fast. They're just realizing what's wrong with them and that they have a disability, and then we send them out the door. So we're really advocating for nurses and other people to kind of follow through with them once they get home to make sure they're safe and so they don't have to come back again. This is sort of, I don't know how long I'm going to be in this stroke role for. I've been here quite a while, but I'm excited to see what will change in the next couple of years. I hope I'm not giving Race a foreshadowing of what her future. No, I'm just kidding.
Oh,
But I guess to summarize, in conclusion, before we do a couple case scenarios, strokes can present similarly, but require different treatment methods. The gold standard for stroke care currently is alteplase and thrombectomy if there's a large vessel occlusion. LVOs, large vessel strokes, and posterior strokes can be identified using the enhanced FAST-ED tool. We would encourage you all to watch that video again and think about putting it into your practice. It should be chartable in your pre-hospital record, depending on what you're using. We're working on Susie to make sure it's in all of them. Pre-hospital care is obviously super important. Recognition of stroke and accelerating treatment and communication is key, and time is brain. And time is spine too, I like that, but time is brain. We're gonna win this. Do you guys have any thoughts or questions? We have 4 case scenarios that kind of build on these ideas, and we have some spots for questions and comments from the group throughout these.
Josh, you want to take a quick 10-minute break for stretch, recough, caffeinate, and reconvene?
Yep, sure.
Okay, thank you.
I'm uncomfortable. My ears got violated a lot yesterday at work.
So on Thursday, I was supposed to ride Ian's from 8 to 8, and I walked in and PJ was walking out. And I was like, what is going on? He's like, I'm leaving. I worked yesterday. And I'm like, who? PJ.
Oh, yeah.
And then I was like, so okay, I looked at Dave and I was like, who am I going with? He's like, oh, you'll come with us for a few hours. I was like, okay. Well, at 3 o'clock, there was 3 students there.
They shouldn't be doing that.
So I jumped with PJ, and then I jumped with Webster, and then Tyler had to do an hour. So they were like, oh, we're going home and logging the truck off. I was like, okay, so what now? Because I don't have anyone to ride with.
Was Webster precepting you?
Huh?
Was Webster precepting you?
We didn't go on a call.
Okay, I was gonna say, because Webster's definitely not a precept.
Yes, he's on the list.
No, he's not. He shouldn't be a preceptor.
He's on the list, and it was verified by Dave Samrock.
Don't listen to him.
So yeah, we like jumped around for rig, and then was like, it's like 5 o'clock. Now what? And they're like, oh, you can just go home. And I'm like, okay. So I called
Not on the list.
Huh?
He's not on the list.
Well, it was verified by Dave, who talked to Josh. So I guess we were literally jumping around for the next rig. So
Shit.
we literally, I was like, okay. So I called Nova and was like, can I come ride? And they were like, sure. I was like, okay. So I just finished up my day there. It was annoying.
You told me.
The other time? Mm-hmm. Oh yeah, because I called you. Mm-hmm. Yeah.
Happy dinner, Josh.
Hmm?
Awfully healthy dinner.
That's right.
How many donuts did you have today?
None. 2 oranges, this. But I had McDonald's for brunch, so that kind of.
I knew there was something in that.
I had a donut
I
today
knew
too. I had a donut today because I live right above a donut shop, so I deserved it.
It would be a bad thing for my.
Yep.
Yep, I remember you
It's so
saying
bad.
that.
It's so bad.
So next time we go there, we'll honk. Instead of yelling Stella, we'll yell.
I go there way too much.
But they're sad.
They're so good.
Josh, whenever you're ready, sir.
I'll just give Raisa 1 second to come back.
I am here.
All right, let's pick back up here. So just a quick review, radiology 101 of the head. You're looking at normal CAT scans here. CAT scans are x-rays, slices starting at the base of the skull and going up through the head. The more advanced the CAT scan, the more slices you get. So we have one, the Toshiba, the one that you guys usually go to at Upstate, 356 slices, gives you a lot of detail. That's what that one can take. So in layman's terms, I guess what you need to know is when you look at a CAT scan on the screen in the control room, you see the ham slice here, and on the right side is the left side of the brain, and on the left side is the right. So if you look at your screen, this is how it looks. So it's kind of contra-intuitive, I guess, if you will. The darker area is more what's the word I'm looking for? Light, I guess. And as it gets darker or more white, that's kind of where blood or bone is. So if you see blood on the brain, it will look sort of like this here. So abnormal CAT scans, the image on your left, you can see the white area. That's a consolidation of blood. Blood is thicker than brain, and it's clotting within the head. So it shows up as dense, which shows up as white on CAT scan, just like the bone, which is the cranium. The left side of that, or the right side that you see here, the right image, you see the large area that's darker. That's a ischemic area, not the ventricles in the middle, the kind of P shapes, but the area that's more on the left side of the image. That's dead brain tissue, and do a very good job on that. But if you have questions as you go through, just let me know. And if you're ever in the control room at Upstate, please ask anybody that's in there to help you understand what's going on, what the picture is, if they see anything. There's always a doc there from our team that I encourage to answer any questions asked. It's a learning environment. So if I'm there, you can ask me. We have neuro SWAT nurses also. Just say, what is it? What do you see? Well, that's what we see. We see blood and stroke. So keep that in mind as we roll through. We have a couple images, and then we have 4 scenarios for you and a couple images. So Raisa, I think this one is yours.
And feel free to shout out answers too. So we're just going to present some scenarios, and if you have a solution or a suggestion of what it might be, you can feel free to either put it in the chat or shout it out. But this is a typical, you get a stroke call for a 42-year-old male. You get to the scene, you get the vitals. Of course, you do your blood sugar test. Everything seems to be pretty normal with the vitals. Nothing's too off. But this patient has garbled speech and arm drift. So what would this, how would this score on, let's say you do a CPSS score? Would it be positive or negative? Would this be enough? Positive? Yeah. And this would be enough information for you to think maybe possible stroke. So you identify the last one well. The patient says, let's say maybe he was going up to the bathroom at 1 o'clock and everything was fine, talking to his wife, and all of a sudden, at 2:39 when they called, he developed those, or he figured out he had those symptoms. So you guys get to the hospital, you do a great job of doing a pre-notification call of the incoming stroke. So with a last known well of 1 a.m., and let's say we're getting there around about 2 hours after, would this be a TPA candidate?
Yes.
Yep, perfect. Great job. So basically, yeah, so it looks like a stroke. We're in that last known well within 3 hours. Of course, can always also go beyond that time, but the perfect scenario for a TPA case. So you get to the hospital, the patient goes straight to the CT scanner because you guys pre-notified, the team was there, CT scan was ready, and they did a CT scan, and this is how it looks like. So knowing what Josh showed you about those 2 CT scans where you saw blood and where you saw blood and where you saw completed stroke, that dark tissue, what does this look like? Like if you saw this CT scan, did you notice anything off about it? Well, I'll give you the answer. So it looks like a normal CT scan. It's what we call a CT negative, a CT scan that's negative. We want to see this with a patient that has symptoms, but the scan looks like this, because if this patient had darkening on that CT scan, this would mean that the stroke was completed, and that part that was completed is at risk for bleeding. So you don't want to give TPA to a patient like that. You want a fresh brain where there's still salvageable tissue, where we can still get that clot, dissolve that clot, and basically regain that function of where that blockage is happening. So on the next slide, we get that patient TPA within the 30 minutes of arrival. Patient goes home the next day, they've got a great outcome. So this is why pre-notification is great. It helps with that stroke pathway, gets the patient in the treatment that they should get basically for a stroke. Time loss is brain loss, remember that. Now your second patient, this is a younger patient, but she presents like this with an acute onset of left facial droop. EMS arrives, you guys notice the left facial droop, but she also reports that this started about 2 days ago. So on top of the facial droop, she has some facial numbness, and she's saying that she's having a difficult time chewing. So you get the vitals. Vitals seem okay. Everything else seems okay, but she has these symptoms. They started 2 days ago. This is all in the face. What would you think this would be?
Do we have a VGL?
We actually don't. I mean, we probably should get one. So we do have blood glucose, and let's call it like 113. And her only symptoms are left facial droop, facial numbness, difficulty chewing.
Could it be Bell's?
Mm-hmm. Yeah.
History of Bell's palsy.
Yes. Yeah, I think I heard that a couple times. Yeah, great. Yeah, and this looks like a stroke. You get these patients and you're like, whoa, that's definitely a stroke. But that facial nerve, where you get the Bell's palsy, I think someone was speaking. But just as you can see on the picture, where that nerve goes, that's what it's affecting. It's affecting the eye, the face, and the fact that she has difficulty chewing. A stroke patient wouldn't really have difficulty chewing. They probably have difficulty swallowing, choking, but they wouldn't be letting that go on for 2 days. So this is a basic treatment of steroids, antiviral, some artificial tears to keep the eye out from drying out. But this is a very common stroke mimic. But like I said with these too, if you have a patient that comes in like this, if you do suspect Bell's palsy, still include the stroke as another diagnosis, and let the team get that patient their CT scan, because they still deserve the chance to figure out if it is a stroke, because if it is, you want to get them the treatment. Obviously, it'd be out of the window for a TPA anyway, but she'd at least get the workup. So, yeah, great job.
Our next patient is a 78-year-old female with a sudden onset of left gaze deviation, right-sided facial droop, and aphasia. Right arm and leg are flaccid. Patient has a past medical history of COPD, hypertension, atrial fibrillation, of which she's not on anticoagulation. There's a problem. At 1:15, the patient's daughter calls 911 with suspicion of a stroke or CVA, and EMS is on the scene at 1:30. Let's see. Cincinnati pre-hospital stroke screen, positive, negative?
Positive.
I would say so. All right. How about fast DD? What would we want to do for this one? Do they have any, you have a facial droop, you have arm or leg weakness, she has some speech trouble, and she has eye deviation. We don't say anything about denial or neglect, I don't believe, no. But she's got greater than 4. She's got, enough of these symptoms to indicate possibly a large vessel occlusion. She has atrial fibrillation, so we're thinking there's possibly a clot coming out of her heart and flowing up into her head. What do you want to do next with this patient?
Notify the hospital and rapid transport.
Yeah, so it sounds like this patient was from a little remote site. So I think Krista's on here too. I don't know if the scene sounds familiar to her, but air medical is notified. Ground crew calls for air medical and notified of suspected stroke or possible large vessel occlusion. The team arrives at the scene and the patient's loaded and headed to upstate. At 1500, they arrive. They provide advance notification with an ETA of 10 minutes. And at 15:10, they arrive on the rooftop of upstate. They're taking directly to CAT scan for a CTA. Imaging looks like this. On the left is your non-contrast CT scan without any dye. And the image on the right is your CT angiogram or CTA. And you can see the spaghetti on here. The left side of the patient's head, which is on the right side of your screen, you can see this where it stops here. Do you guys all see that? Doesn't look this, can you see my cursor?
Yes.
Okay, where this break is not equal here. This is what we're looking at. So all of this is dying. CTA indicates a left MCA occlusion consistent with the symptoms. The patient had right-sided symptoms. And at 1600, the patient's transported from the ED to neurointerventional suite for thrombectomy after receiving alteplase. So kind of the goal is to move these patients for thrombectomy real fast, give them TPA kind of on the way. At Upstate, I mentioned we use rapid CT processing. So this image goes up to the cloud and comes back and gives us indication that the patient might have a large vessel occlusion requiring thrombectomy. So pretty cool use of software and smartphone technology to indicate the same thing that a radiologist can see when they look at it. So you can see kind of the bottom on this fake screen here. There's a yellow area that shows the large vessel occlusion is potentially there. The patient may be a candidate. So we use this kind of in adjunct to our clinical decision making. The image is there. We don't want to let computers take over everything. So the patient goes for thrombectomy in IR, and we can see the left MCA clot here, the breakage. As we move along through the procedure, you can see, just like that video we watched earlier, the device going through the clot in the head. And this is what it would actually look like on the screen in the IR suite. And then you can see afterward, the vessels open. You can see kind of the congruent blood flow here, but it looks like there's another clot that forms toward the end there. But it's a smaller vessel and we're not as concerned. It's more risky to take it out. So what we get is visible in front of you, and you can see these are pretty good sized clots. The morphology is consistent with an atrial fibrillation. They generally are larger and look kind of different than other types of clots, and you can see these are pretty big guys. And if you imagine all the blood that this large clot is blocking, that's why this patient presents so dramatically with their large vessel stroke. Any questions or thoughts about that one? We have a pretty good system of care in New York State, at least central, northern, and mid-state, where we make sure these patients are kind of expedited to stroke centers for imaging and thrombectomy. So we all work well together in the region. This patient number 4 is a 66-year-old male who wakes up at 9 a.m. and the wife notices the patient is drooling and not speaking. Patient has a left gaze deviation and not moving a right arm or leg. Patient intermittently following commands with his arm. What does it say? Left arm, sorry. The patient went to bed at 2300. Past medical history on this one, hypertension. The patient had COVID 3 weeks ago. At 9:10, the patient's wife calls 911 and EMS arrives on the scene at 9:25. Notes the same as above with vital signs as you can see here. Blood pressure is a little high. He's got a history of hypertension. That makes sense. Everything else looks okay. What do you guys want to use for your last known well time for this patient? Wakes up at 9, went to bed at 2300.
2300.
What would you like to do given that his last known well is the night before? What are our options for this patient?
I'm still going with stroke and implementing all that, even though last note it's outside the window. I would still get it notified and all that stuff too.
Yeah, there's still something
It's
that we can
potentially
do.
outside the window.
Say it again, sorry.
It's potentially outside the window because sleeping, you don't know.
Right, right. And there is some evidence, and this is going to sound wild, there's some evidence that supports that most of these wake-up strokes end up happening around 5 or 6 in the morning. As the sun comes out, your body starts to change the hormones and it wakes you up. And there's evidence that supports that that might be enough to cause some activity that could cause the stroke. But all we know clinically is a patient went to bed at 2300. And right now, with what we know, that's all we can do. So potentially still in the thrombolysis treatment window, but probably out of a TPA window. The patient's 40 minutes from Syracuse. Also, what will that impact anybody that's coming from not in the Syracuse metro area? What do you want to do with this one?
Call for air medical.
You want to get them here quickly. So it looks like EMS contacts medical control, notifying the desire to transport the patient to Syracuse with suspicion of large stroke. And they provide advanced notification to upstate while en route. So it looks like they're going to come in ground. I think they were trying to figure out if they wanted to go to kind of a stroke center that may be primary or capable of only giving alteplase, when in reality this patient probably has a large vessel stroke that needs thrombolytics. So medical control helped guide the transport destination, but I agree, depending on which direction the patient was, air medical could have been a nice option also. So we receive activation. This is kind of what my phone looks like on a day-to-day basis. I get all the stroke pages as a text. You can see all of the information that you communicate with our ED team shows up on our pagers. So Ray's and I get it. The entire stroke team gets things like this for all the stroke codes coming in. It gives us all the info. We put FastED on that notification also. So if your teams are reporting FastED out to our docs, they can tell it to the whole team, which is super useful. Let's see, patient gets to the hospital 10:40. Is taken directly to CT scanner. They receive a CT angiogram and perfusion. And our perfusion looks like this here. So I think this is the example I used earlier. Reminder, the pink is the ischemic area, the dead tissue, and the green is the penumbra, the salvageable, the goal for the thrombectomy. Our ratio is the key, and it's greater than 1.6. So we want to take this patient to thrombectomy most likely. We found out the patient has an occluded right ICA, a large vessel leading up to the head, and you can see the before images and the after images. The spaghetti indicates brain flow coming back to the head, memories back, and function back as well. So it looks pretty cool afterward. You can see quick results right on the table for these patients. Oftentimes, if they're flaccid on their left side, you get their reperfusion, and all of a sudden they're moving the left side and trying to push you out of the way. So pretty cool results pretty fast there. And no presentations complete without a cute puppy picture. And I think that's all the information that we wanted to convey to this team. So I'll leave the cute dog picture up and open it up to questions or comments, feedback, any cool cases, interesting that you want to talk about while you have us here.
Now, Doc, I got a question here. With the patient we just had there with the 40-minute transport time, the other thing you have to look at from like my perspective, because 40 minutes is realistic for me because I've done almost an hour transport with a stroke. But depending on the scenario, you've got to look at, by the time you realize it, now you got to call for air medical. Air medical's got to mobilize. It's going to be maybe, Krista might be able to help here, but it could be 10 to 15 minutes before you can lift. Then you got flight time to get to wherever you are. it seems like sometimes, most of the time, if you're under an hour, it's probably better off just to ground transport on a priority. And just my line of thinking, is that seem accurate? I mean, Krista, can you help out a little bit on time-wise if you're still here?
Yeah, I'm still here. Yeah, so those are all things you guys have to consider in your plan of care for the patient. If the patient requires airway management, we have RSI capabilities, so that's something else to consider. We really encourage people to put us on standby if the requester is greater than 15 miles away from our base where the aircraft is located. We auto launch and start flying that way. And then when you get on scene and you assess the patient, you rule out hypoglycemia and such, and the patient needs to be flown, we can set up a landing zone anywhere that has 100 by 100 feet, you know, baseball field, soccer field, whatever. So when you're getting those calls for the strokes and the symptoms and it sounds legit, don't hesitate to put us on standby. If you get there and they don't look like they need us, you can stand us down and we just return to base.
Yeah, that's a good point. And also, I think, you know, people that are not native to Syracuse don't understand, our weather, our lake effects, specifically our weather, and also the coordination that you mentioned, both Krista and Nick, I think it was. They say they're coming by air. Why did it take so long? But I say this is the coordination and effort. They have to, EMS has to, ground has to meet them here if it's fixed wing. Then they fly. Then they meet again at Syracuse Airport. Then they come here. It takes a while. So those are all things that we're trying to help our team understand. There are limitations, and we kind of don't always say air is best, but more so have the conversation of what are the factors, what's the best way that you, the person on the other end, thinks that they could get here. Good points though, definitely.
Yeah.
Any other thoughts, questions, perspectives on stroke care? I still think it's exciting, and I think of the neuro disorders, stroke is something where you can see a positive outcome from your treatment and your efforts. You know, ALS, MS, they're all kind of degenerative, and there's not really too much you can do. But stroke, really, fast treatment, time is brain mentality can really give these patients great outcomes. And we've really seen some good things happen because of, you know, coordinated efforts and time is brain mentality for these patients. So young patients that are recovering completely, going back to their normal lives, back to work, is really our goal here. And I thank you guys for all that you do to make this happen, because it really starts with you. So appreciate that. And happy EMS week, happy Stroke Awareness Month. We meet here in a lovely relationship. So I thank you all.
Oh, and Thursday I got to.
All right. Anything else?
I actually just wanted to share like a little fun call that I had.
Mm-hmm.
So it was actually my very first call as an EMT ever, and I went to a house where
teachers and instructors.
Like, well, he just had a stroke a few days ago. He actually just came back from the hospital because he had a TPA. I think that was the day he was discharged, and come to find out, it was symptoms from the TPA that presented as a stroke, but it wasn't actually the stroke.
Did he have a bleed?
Yes, I believe that's what it was.
Okay. Huh.
Interesting.
No,
the bleed rate post TPA is low, but you know, depending on the patient's blood pressure, that can really help. It's generally 6% or less. But if your blood pressure is, you know, wild, maybe this patient had wicked hypertension when they got home, and it was just enough to cause something to happen. That's an interesting first stroke call for you.
My very first call, yeah, it was pretty cool.
All right. Well, thanks for sharing your stories and your time and all of your work. Thanks for all that you do.
Time. Thanks for listening to us. I'm happy.
Josh, I think I can stop sharing and give it back to you.
Okay. Appreciate it. Thank you very much. Wonderful as always. And I really like the addition of the spine thing this year. I was, like that.
Yeah, he loves to teach, and I think he'd probably be happy to come back. He did a nice job. I like him.
Oh,
All right. Well, thank you all.
All right, thank you guys.
Have a good night. Stay safe. Enjoy the summer that's coming.
That was
Bye.
absolutely great getting the spine portion in there, Van. I've seen a couple spinal fractures just to see the other side of the story. So that was neat.
Nice. Yeah,
Good,
we
good.
enjoyed that. Alrighty. All right. Bye-bye, guys.
All right. Thank you. Bye.
Okay, I got real quick stuff for you, and then we are done for tonight. Neuro Night 2 will be on Thursday. I got an email earlier asking more specifically about finals. So finals week is the week of 4th of July. Right now, I've published on FISDAP 3 tentative times. I'm going to start at 10 o'clock right here in this building in the front. How many people do not have a laptop? AKA would need me to have a laptop here. So if we're going to test in the building, that I would need to provide a couple computers, because I can get a couple of computers, I just can't get 30.
I know mine doesn't connect to the internet here.
That could be a problem. We can work on that.
Josh, it's RT. Josh, does Chromebooks count, or do they?
Will it access the interwebs?
Oh, I can get you as many you need. I can, like if like 20 students need them, I can get 20. I can borrow them for a day.
Okay, we'll cross that bridge when we get there. But first, let's find out, does anyone have a problem and could not get a computer or have a laptop for the day? All right, I'm seeing a lot of attendance, but I'm not seeing a lot of no's or major problems getting flagged. Okay, so with that being said, we're going to test in 3 large groups. Tuesday from 10 until 2, and then another group 10 until, and from another group from 2 until 6. So it's 4 hours to take the test. That gives you your maximum amount of time allowed, but doesn't mean that you have to take the whole time. When you're done, you can say, cool, I'm done. Give me my test. I'm out of here. Fine. Are we good taking it?
Wait, can you say that again? You want to test on what day?
So right now I tentatively have Tuesdays and Thursdays. I know some people work 4 on, 4 off. I need to make sure there are no conflicts there. If I need to move a date, I'll move a date. So I'm looking at right now, July 6th and July 8th.
And where do we sign up for this?
That is directly on FISDAP right now, live. Yes.
Josh, either of those dates should work for me. I just don't have my work schedule until I get back into New York late this weekend.
I get it. If those dates are an absolute no-go and you cannot make arrangements, I need to know ASAP. We will see what we can figure out. So it should be FISDAP in July on the calendar. Should be the 3 blocks of time I've set up. The other question was about possibly changing our ACLS PALS, our letter classes. So ACLS letter classes right now, the university has changed its policy. It does not see that policy being changed back anytime soon. So we are not going to modify our schedule. We are going to go with the Friday, Saturday combo that was originally posted for ACLS PALS. Come on in for the lecture. We're going to do labs all day, scenario-based for ACLS PALS, PHTLS, and AMLS for the original calendar. What?
Hey, Josh.
Per the original schedule. I don't know the dates off the top of my head. I really don't. Yes, question from online.
Hey, Josh.
Yes.
Yeah, it's not visible in FISDAP right now.
Yes, it is. I just found it.
I'm gonna let them tell you. Yes, it is. But yes, it is.
Maggie, can you show us?
Yep, they just look like regular lab shifts in July.
You got to make sure your search bars are not searching for upstate and or community or peds. If you clear it completely, it'll show up yellow. Just hold your cursor over
Look
it.
at
And it'll
that.
highlight.
Looky, found it. Never mind, I stand corrected. I was wrong.
It's all good. Okay. Boom, shaboom.
We can do either Tuesday or Thursday.
Yes. Again, we're going to maintain our dates from the original calendar for ACLS PALS, all those fun jazz. Skills. Remember, get your ride time done, get your phase 2 stuff all locked up, wrapped up. You can even submit your phased advancement if you're done. That does not mean that you have to be done riding. So if you happen to be done with your calls and you just want to get the paperwork out of your hands and into mine and make it my problem, submit it. Okay? Continue to ride if you have all your calls, or you want to do a little bit less riding or do whatever you got to do. Make sure you get the stuff done. Remember, it's all due July 1. All your ride time needs to be buttoned up, neat little bow, paperwork submitted. If we have to extend into July for clinical, we understand we have some scheduling funsies there, but ultimately everything has to be scheduled out for your completion on or before July 1. So July 1, I just need to see on your calendar if you had to extend into July time. Other than that, a reminder, if you are doing calls with your preceptor, make sure that you are submitting your paperwork online, on time, and complete paperwork. Make sure it's signed, filled out, dated, those typical things. We've seen a little bit of laziness lately in paperwork, general coming in without signatures, without dates. Stuff needs to be signed, stuff needs to be dated. Make sure that you're submitting electronic copies, so I have it. If you're working a call, you're working the call. We can't have you show up, do some fun stuff, and then leave. If you're going to do a call and you're going to count it for an ALS call, it has to be the full shebang. Okay. Obviously, if you show up to help another crew and they're working on an arrest and we don't transport, but you do a lot of stuff, that's the entirety of that call, right? You showed up, you did some stuff, you throw in a couple of moves, but you were there for the entirety of the call until you were like, we're done here, goodbye. That counts, but you must be there for the duration of the call. Phase 3 preceptors need to be submitted by your final. You can even bring them to your final and hand them to me at your final. Your final is a cumulative 200 question exam. Everything from start to finish. You have 2 attempts to pass that exam with a 70 or better.
RT has a question.
Sorry, hi, hello.
Of course she does. You gave us like the test prep stuff to work on, and I noticed, like you said, it was like the general areas, but there's like lots of chunks missing, like toxicology, like things that
falls under medicine.
Okay, I was snooping around and like okay, so it's from those things that you want us to be working with. I feel like it wasn't everything.
So it's all there. It's just not every single solitary subject. It's not all 100 questions per chapter that I have access to.
Okay. Okay. Thank you.
Maggie, what else was in your email? What was your other question? Dates.
The CME one, you covered the other 2 questions that people asked me. The CME one.
If people need to submit regional CMEs for regional CME hours for your EMT card, you guys automatically get that from the EMT class. What I will do is I will write a generic one. I will sign it. Any of you are welcome to come and get it from me. Here it is. Here's your copy of all of your classes that you've done. Your CMEs are done for the semester or for the year for your agency, so nobody comes barking at you that you need to turn stuff in. I will have those ready by class time on Thursday. That work for everyone?
Thank you, Josh.
Okay. Good night.
Good night.
Good night, all.
Work on that momentarily.
ACLS and all those classes. What was, oh, the days. Because weren't
Yeah.
they supposed to be like Saturday and Sunday?
They're gonna remain the Friday and the Saturday.